Good morning, friends.
Good
My name
morning.
is Andre Boville, current chair of the Medical Benefit Schemes Medical Formulary Committee. I'd like to welcome you to the Medical Benefit Schemes Formulary Committee Continuing Medical Education sessions. Today we start our first in a series of CME sessions. This exercise undertaken by the Formulary Committee is being done with support from our board, Medical Benefit Schemes Board, headed by Chairman Mr. Osbert Frederick, along with support from our CEO, Mr. Kevin Silston, and his team of executives. Additionally, we are also being supported by the Medical and Pharmacy Councils of Antigua and Barbuda, as well as the Medical Association of Antigua and Barbuda and the Pharmaceutical Society of Antigua and Barbuda. Our series of CME sessions, colleagues, form the second part of our three-pronged approach to sensitizing our health professionals of the changes made to the Medical Benefit Schemes formulary, more specifically our approved drug list of 2020, with adherence to new treatment guidelines for the management of chronic conditions such as hypertension and diabetes, among others. I must recognize the efforts of my predecessor, Mr. Aldosterone Roberts. Credits to him, because it's under his leadership that the process of revising our formulary / our approved drug list began way back in 2019. Recognition must be given to our committee, which comprises of Drs. Sharon Cordner and Ian Thomas, along with pharmacists in Mrs. Sharon Butters, Mr. Bridgewater, Mr. Alfred Attil, Ms. Sandra Jonas, Karen Benjamin, Mrs. Butters, and myself. For we've ably continued the trust of moving things to the next phase. And so in July of 2021, we had our rollout of our approved drug list. And following that, we addressed several concerns of our physicians. And now we embark on this, the next step of sensitizing the wider health community of our changes made to the list. Colleagues in Antigua and Barbuda and further afield, thank you for joining in on these important sessions starting today. We have the privilege of hearing from some of the foremost experts or specialists in health, medicine, and pharmacology across the region. Persons that in some measure would have helped us to be where we are today as a committee. I urge that we make full use of these sessions. May we apply ourselves to consuming much of the knowledge and I dare say experience that will be shared and transferred. Expertise that would have been gained from many years in practice and of engaging with the literature, as well as being active research. We are indeed fortunate to have these esteemed experts among us. I'm confident that with the information shared through these sessions that our patients, our beneficiaries here in Antigua and Barbuda and the wider Caribbean and elsewhere will no doubt be the ones who will truly gain from all this. The sessions will provide a chance for us to inculcate best practice within our work sphere. Thanks for joining in. The Formulary Committee of the Medical Benefit Scheme do look forward to your full participation in this endeavor. Thank you.
Thank you, Mr. Boville. Good morning, all. I am Dr. Sharon Cordner, consultant in internal medicine and rheumatology, and today I will be introducing your speakers. Our first speaker for this morning will be Dr. Georgette Meade. Dr. Meade is a 2009 graduate of the University of the West Indies with MBBS, and she went on to do internal medicine at the same University Mona campus in Jamaica. Following that, she did a fellowship in cardiology at the University of Toronto, which is affiliated with the Peter Monk Cardiac Center, Toronto General Hospital. She's a member of the medical associations, including the Caribbean Cardiology Society, European Society of Cardiology, and Canadian Cardiovascular Society. She's also an affiliate member of the American Heart Association. She currently works as a consultant cardiologist and internal medicine specialist at the Hope and Grace Center, and she's the co-founder and president of the Heart and Stroke Foundation of Antigua and Barbuda. Dr. Meade will be addressing us on the advances in the management of heart failure. Thank you, Dr. Meade.
Dr. Meade, just pause a bit so my technician can unmute you, please.
Thank you. Thanks again for the invitation. And thank you for the introduction, Dr. Cordner. A lot has been happening in cardiology and heart failure in particular. And so I'll be providing some updates in terms of where we are. And there are quite a few drugs that are now available on the formulary. So I'm pleased about that. The patients have been benefiting significantly. So I'll share this information with you now. I'm getting a message, host disabled, the participant screen sharing. Yes, I'm still getting that message. Okay, I'm getting access now. So what is heart failure? Quick review, a clinical syndrome where the heart is unable to maintain adequate cardiac output to meet the body's demands, or does so at an elevated filling pressure, both of which are hazardous to the heart itself and the rest of the body. It is a progressive disease, and we should remind our patients of this. Many of them stop their medications when they feel better, and that's a very hazardous thing to do. So we should educate them of this from the beginning. It is a growing epidemic. We are very concerned, an estimated 64.3 million persons worldwide. And the mortality at 5 years is 50%. And we do see many of our patients returning with exacerbations. So 83% at least once, and 43% up to 4 times, at least 4 times. And I know the emergency room physicians, the internal medicine team, we can vouch for this definitely. And so how do we limit the mortality for patients and reduce the hospital admissions? So we'll be speaking about some advances in the care of our patients. The classification, this is according to the European Society of Cardiology. They divided heart failure with reduced systolic function, LVF of less than 40%, heart failure with mildly reduced systolic function, LVF between 40 to 49%, and heart failure with preserved systolic function, LVF of less than 50%. Broadly though, we group it greater than 50% preserved and less than 50% reduced systolic function in terms of approach to management. And then there's also the classification of systolic dysfunction versus diastolic dysfunction. The pathophysiology, so decreased cardiac output. The heart is the pump which supplies oxygenated blood to the rest of the body. And so if it's unable to do that, all patients will become symptomatic. And then there's decreased carotid sinus firing and an increased sympathetic discharge. So many of our patients will be tachycardic, and some may actually have atrial fibrillation or ventricular ectopy with ventricular tachycardia. So arrhythmias are a concern. The sympathetic discharge is to help with improve the cardiac output. And so this is why the sympathetic discharge also occurs. And then there's also increased preload and an increased afterload, all of which are hazardous to the failing heart. And then the synergy with the heart and the kidneys, with a decreased cardiac output, there's decreased renal blood flow. Renin is released and angiotensin also. And so this also leads to an increased afterload and a remodeling of the heart, which is also hazardous for the heart. And so it's a negative spiral that if we don't stop it, the process, the heart deteriorates, the patient progresses to advanced heart failure and unfortunately may die. So we will get into the routes of action of some of the medications as I go further along. Now, what do we mean by systolic versus diastolic heart failure? The heart fills, and that's diastole, and systole is the pumping action. So with systolic heart failure, there's an issue in terms of the heart not pumping the blood out, the adequate amounts of blood out. Oxygenated blood, that's required by all of the tissues. The chambers are also stretched and become weaker. And then in diastolic heart failure, there's thickened and stiff ventricles. Less blood is able to fill. As you can see, the cavity is smaller, and hence less blood is able to fill. And in addition, less is going out to the systemic circulation. The contraction strength, however, remains normal. And these patients usually have an ejection fraction of greater than 50%. Now, why do our patients develop heart failure? There are many causes, ischemic heart disease being one of the #1 causes, hypertension in our population, valvular heart disease, cardiomyopathies, congenital heart disease, pulmonary disease, for example, COPD, and arrhythmias. The patients on chemotherapy, they should get an echo pre-chemo and during treatment and after treatment. The anthracyclines in particular do lead to a dilated cardiomyopathy, or there's a risk of developing a dilated cardiomyopathy. Radiation, alcohol use, excess alcohol use, and uremia, infectious diseases, COVID-19, influenza, HIV, and the others are listed. Endocrine disease, so patients with hypothyroidism, we need to screen them if they're having symptoms suggestive of heart failure. Infiltrative amyloidosis, it is present in our population, and so we must be cognizant of this. The ejection fraction may actually appear normal or abnormal, but there's significant left ventricular thickness on echocardiography. Genetic conditions, peripatent cardiomyopathy, I've seen quite a few of these patients since my return home. The good thing is they do respond well to treatment, and so we should treat them aggressively. Stress-induced cardiomyopathy and tachycardia-mediated cardiomyopathy. So if your patient has a tachycardia, the goal is to quickly get them back into sinus rhythm because they can develop a cardiomyopathy in the long term. Now, I would like your help as we manage this patient. He's 62 years of age. JD is his name, and he's of African descent. He came in, he reported having a flu about 6 weeks ago, He's also diabetic and hypertensive. He had bilateral leg swelling for 3 weeks, which has gotten progressively worse, and shortness of breath also for the same duration, P&D for 4 days, and scrotal edema for 2 days. And this is what really prompted him to seek medical attention. So the vitals, the blood pressure, 110/62. He's mildly tachycardic at 108, respiratory rate of 24, and an O2 sat of 95%. So we then, what next will we do for JD? What additional questions do we have? So this approach, we want to get more from his history. Has he ever had a myocardial infarction or PCI? Any history of hypertension? So yes, JD does have hypertension. No prior history of cardiotoxic treatment, drugs or radiation. He has never been on diuretics, but he does have orthopnea and P&D. And when we examine him, he has bibasal crepitations. His bilateral ankle edema, it actually extends up to the knees. A systolic murmur, so pansystolic murmur, was heard at his apex, 3 out of 6 pansystolic murmur. And he does have a displaced apical beat. We are concerned about his tachycardia, so then we're going to get an ECG done. And it shows that he's having sinus tachycardia. Now, our next step, the BNP. As far as I know, BNP, we have to get that sent overseas. And so we use our clinical acumen most of the time. And then we move on to the echocardiogram. If there's none of these symptoms or background information, heart failure is unlikely in this patient, but sounds very likely for JD. So we move on to his echocardiogram. And then what else can we do initially? I'll be using this slide several times as we go through the steps in terms of the management. So we will also want to get his complete blood count. Anemia is a risk and needs to be treated pretty aggressively. The basic metabolic panel, what's his kidney function like? Is there chronic kidney disease or acute kidney injury? The potassium level, we definitely want to get these information. The liver function tests, they can develop a transaminases, and because of enlargement of the liver, we want to get his liver function test, iron studies, thyroid studies, his HbA1c. The chest x-ray, very important too. And as guided by his presentation, whether a coronary angiogram is required, cardiac MRI or biopsy, these are some additional investigations that might be required. So we've done his echocardiogram, and it shows a dilated left ventricle. This is the left ventricle. The left atrium is also enlarged, and his ejection fraction was 30%. He also has a mitral regurgitation, which likely is leading to the enlargement of his left atrium. So why do we manage our patients? What's the goals of management? We want to improve his symptoms. He's having several symptoms. We want to slow the disease progression and prolong his survival, knowing that the mortality is pretty significant. So this, we will classify his symptoms using the New York Heart Association classification. NYHA class 1 means no symptoms with normal physical activity, normal functional status. NYHA class 2, he has mild symptoms with normal physical activity, comfortable at rest, slight limitation of functional status. NYHA class 3, moderate symptoms with less than normal physical activity, comfortable at rest, but marked limitation of functional status. And NYHA class 4, they have severe symptoms with features suggestive of heart failure with minimal physical activity and even at rest. So JD, he's between NYHA class 3 and 4. At this point, I'll actually put him into class 4 NYHA. Why is that important? Classifying the patient, many of the guidelines quote the NYHA classification. And we then determine the aggressive nature of treatment required and what options for treatment we should choose. We are all aware of the ACE inhibitors, should be started once the blood pressure allows. A beta blocker should also be added on. I'm pleased to see that Bisoprol is going to be added on to the formulary and or has been added to the formulary because it is one of the guideline-directed beta blockers, in addition to carvedilol and long-acting metoprolol. So those are the three options we have for patients with heart failure. It is a class 1A recommendation, and we add on a mineralocorticoid receptor antagonist. Available in Antigua is aldosterone or spironolactone. And these three medications should form the basis of management. This is what we've been doing for years. Our patients have had benefits, but here comes along the ARNI, we call it for short, which means angiotensin receptor neprilysin inhibitor. Vermatta available locally, and we need to prepare the specially authorized drug form so patients would have the benefit of this. I'll explain later how it works and the significant benefits of this medication. So I'm pleased that we do have it available. And for my day-to-day practice, many patients have benefited. And I'll explain to you why it has been such a paradigm shift in the way we manage patients with heart failure. So it is preferred. So ARNI, ACE inhibitor, and ARB, but the ARNI is preferred over the ACE inhibitor and ARB. So once a patient can be placed on it, that will be our first choice. The evidence-based beta blockers, as I mentioned, and a diuretic agent. That's the first tier of management for the patient. So just a little quiz to see what's our next drug. Probably when JD comes back for follow-up, what next might we be able to add, or if he's admitted, before discharge, we should actually start another medication. So here we are. So for patients, I want you to think about what you'll do. So for patients with eGFR greater than or equal to 30 mils per minute, or creatinine of less than or equal to 2.5 in men and less than 2 in females, the potassium is also normal, and his NYHA class 2 or 4. I'd want you to think about what option we might add next. Then for patients, another new drug available, I'll give some information about its benefits, another group of medications. So I'm kind of giving you an idea. So ensure the eGFR is greater than 30 mils per minute for dapagliflozin, and greater than or equal to 20 for empagliflozin. So if you know what group these are in, then I sort of gave you a hint. We want the patient, and so JD, he's persistently volume overloaded. We've started our initial dosage. Which one of these medications can we titrate for his fluid overload? And then for persistently symptomatic Black patients, despite being on all the evidence or the guideline-directed medical treatment, he is still fluid overloaded, he is uncomfortable, unable to sleep well at night. What can be our next option? And then for patients with a resting heart rate of greater than or equal to 70 on maximally tolerated beta blocker dose in sinus rhythm, NYHA class 2 to 3. So I hope you're able to come up with some responses here. Now I'll show the answers. So I hope you got it. Aldosterone antagonists would be this group. It is a potassium sparing medication. And so that's why we want to make sure the potassium is normal and the kidney function is normal. So aldosterone is what we have available, or spironolactone, same medication. In this group, it's the SGLT2 inhibitors. These came about coincidentally. They were actually being a new medication for diabetes. And then in patients with diabetes and heart failure that they were used in, they saw the profound benefit of this medication for the heart failure patient. And so they investigated it a bit further, and they are now part of the guidelines for patients with heart failure. So I'll speak about these because these are one of the advances in the management. We want to titrate JD's diuretic treatment, and the hydralazine isozolbide dinitrate in the African descent patient has been shown beneficial. And then ivabradine is the one that we need to make sure the patient is in sinus rhythm, optimal medical therapy at the maximum dose for the beta blocker, then we can consider adding on ivabradine. Just a reminder in terms of the use of each of these medications. So the ARNI, Vermatta, we call it, is the type we have available locally. And you should know Entresto, because if you have a tourist or a visitor coming from the US or Canada, Entresto is actually the same medication, right? So the heart failure with reduced ejection fraction, the EF of less than 40% is when we're able to start. NYHA class 2 to 4, and we administer it in conjunction with the ACE inhibitor ARB. So in place of it, so if a patient is already on one of the ACE inhibitors or ARBs, we can transition off. If they are on an ACE inhibitor, you need to stop the ACE inhibitor for 36 hours before the RNA is started. 36 hours, you stop the ACE inhibitor. The ARB, you don't need to because the ARB is one of the contents of the RNA. So we'll talk about that later more. Indications for the use of ivabradine. So the ejection fraction less than or equal to 35%. They are maximally tolerated dose of beta blocker. The heart rate is greater than or equal to 70 beats per minute, and they are in sinus rhythm. NYHA class 2 or 3. Ivabradine can be started. And the SGLT2 inhibitor, EF less than or equal to 40% with or without diabetes. So even in the patient who is not diabetic, the SGLT2 inhibitor can be started. NYHA class 2 to 4. And the other guideline medical directed therapy should already be started before we add the SGLT2 on. All right, so the ARNI, ivabradine, and SGLT2 inhibitors. I wanted to go over the medications, the guideline-directed medical therapy, because there are a lot of medications available, but I wanted to highlight which ones are specific for heart failure and have been studied and shown to be beneficial. So Bisoprol, as I said, has been added on to the formulary. Carvedilol we do have available, and Metaprolol succinate. That's the once daily Metaprolol. The twice daily Metaprolol has not been shown to be, well, it was not studied. So the once daily Metaprolol was the one that was studied and shown to be beneficial. The starting doses are highlighted here, and also the target doses. Once the patient can be up-titrated in terms of the doses, we should aim to do that. Hypotension and bradycardia sometimes limit us, but we should aim towards getting them to the target doses. The RNAs, sacubitril, valsartan combination, the starting dose can be 50 to 100 milligrams twice daily with a maximum dose of 200 milligrams twice daily. Captopril, enalapril, lisinopril, and ramipril are the ACE inhibitor options. The ARBs, candesartan, losartan, and valsartan. Aldosterone, spironolactone, we do have available, and the eplerenone. SGLT2 inhibitors, dapagliflozin and empagliflozin. And vasodilators, hydralazine isozolbide dinitrate has been available on the formulary, and ivabradine also available as procoralan. So please take note of the starting doses and the target doses. So I mentioned the evolution, the advancement, the great benefit of the RNA, in particular Vermatta, as we are more familiar with. Why are they so beneficial, and what are the benefits? So here they are, published in the Paradigm Heart Failure Trial, published in the New England Journal of Medicine. Death from cardiovascular causes, there was a 20% risk reduction in death from any cardiovascular cause, 20%. And it was statistically significant. Heart failure hospitalization, there was a 21% risk reduction. Each time the patient is admitted to the hospital, their mortality risk actually increases. And so in some hospitals, especially in North America, they monitor the heart failure team's management by whether or not the patient is admitted again. So our goal is to get them adequately diuresed once they're admitted, remind them again about salt and fluid restriction, compliance with the medications. If there's any issue with the meds, are there other options that they could actually be treated with? So the hospital, readmission to hospital is a parameter that is used to assess their management overall. And so with Vermatta, there's a 21% risk reduction. And then death from any cause, there was a 16% risk reduction, also statistically significant. And so the evidence has shown the profound benefit of the ARNIs, Vermatta, as that's what we have locally. All right. So just a bit of pathophysiology and how this drug actually works. It is a combination treatment. So sacubitril is an addition. We are familiar with valsartan and the benefits of the ARBs. So I'll go over that. It blocks the angiotensin combining to the receptor. And why is that blockage important? If it's stimulated, what happens is sodium and water retention. Definitely a no-no in the patient with heart failure. There's vasoconstriction, increased sympathetic tone, and proliferation. These are all in the pathway with remodeling, which is not helpful for the heart at all. And so we well established the benefit of valsartan in the patient with heart failure. Then the sacubitril, it's converted to sacubitralate once it gets into the body. And what this does, it blocks neprilysin. Why is that important? Well, before we get there, in the patient with heart failure, there's ventricular wall stretch, and proBNP is released, and this is then broken down to BNP. And the nitric peptides, they lead to natriuresis, so they get rid of extra sodium. They help with diuresis, vasodilation of the arteries, there's decreased sympathetic tone, and anti-proliferative action. So that's the action of the BNPs, natriuretic peptides, which are actually helpful in the patients with heart failure. And so neprilysin usually breaks down the natriuretic peptides. So if we could have the natriuretic peptides available for a longer period of time, then we'll get these benefits in our patients with heart failure. And so in the combination of both of these medications is why we're seeing this profound benefit from the ARNIs. And I hope you share this excitement. So I'm put it into words again. So sacubitril is a neprilysin inhibitor. Valsartan is an ARB, and it's available as Vermatta and Entresto. So the precursor hormones proNP and proBNP are mainly synthesized and released into the circulation by the heart in response to myocardial stretch, of which is part of the physiology of the patient when they develop heart failure. There's also hemodynamic changes and inflammatory stimuli. So when the patient takes the Vermatta, sacubitril is broken down to sacubitralate. Then neprilysin, as we mentioned, degrades the BNP, but we don't want the BNP degraded, we want it available. And so sacubitril blocks neprilysin action. And the beneficial cardiovascular and also the renal effects of the ARNIs, there's natriuresis, vasodilation, suppression of hypertrophy and fibrosis, inhibition of the renin and aldosterone release, and reduction in sympathetic activity. And phenomenal benefit. I've seen it in the office. I've seen the patients respond to Vermatta, and some a great advocate for Vermatta treatment. And the valsartan, we know it's angiotensin 2. It blocks angiotensin 2 and aldosterone action. So we go back to our guidelines, the 2001 update for heart failure management. So there's the ARNI, now frontline treatment, preferred over the ACE inhibitor or the ARB. So we use them one or the other, not together. If previously on an ACE inhibitor, as I said before, we needed 36 hours off of the ACE inhibitor before the ARNIs commence. And how do we decide what's the best dose to start? So if the patient was on less than or equal to 10 milligrams of enalapril, lisinopril, or an equivalent dose of less than 160 valsartan, we start at 50 milligrams twice daily. However, if they want 20 milligrams of lisinopril, or even 320 milligrams of valsartan, we start at 100 milligrams twice daily, right? And we want to keep a close eye on the patients. They shouldn't come back in 2 months to see you. You should actually be seeing them at about 2 weeks later. Did they tolerate the medications? What's their blood pressure like? You also want to check their electrolytes and their kidney function overall. All right. And similarly, if they're on the ACE inhibitor or ARB. The beta blockers we did go over. You want to assess their heart rate, their blood pressure, and did they go into heart failure? Because we must remember the patient should not be in active heart failure when we start the beta blockers. That can make the heart failure worse. They should be diuresed first, and then we can commence the heart failure medication. If they've been on beta blockers long-term already, you continue the beta blocker unless they are bradycardic. That's the only reason you'll stop it, but not because of the heart failure. So if you're on beta blocker long-term, continue the beta blocker. But if it's the first time on the beta blocker, they should be adequately diuresed before you start the beta blocker. Diuretics, just something, a little tip. If the patient is in atrial fibrillation, just diuresing them a lot of times, atrial fibrillation and heart failure, just diuresing the patient actually causes the atrial fibrillation to slow down or even convert to sinus rhythm. If that doesn't work, then you would have to definitely use treatment. But in the beta blocker naive patient, amiodarone is also an option to get the patient into sinus rhythm. But diuresing them a lot of the times does cause the atrial fibrillation to slow down or convert to sinus rhythm. All right, so how do we decide what to choose? Lasix is what we use commonly. Metalazone is another option available elsewhere, but Lasix has been doing the job most of the time. But then if it doesn't work, we titrate it up. But if it doesn't work, we can then use metalazone. And sometimes adding on a thiazide diuretic is also beneficial. When we are doing that, though, we need to monitor closely the patient's blood pressure and the electrolytes, potassium in particular, and the burn and the creatinine. And aldosterone antagonists, potassium should be monitored. Remember, these are potassium sparing, so a lot of them can become hyperkalemic. And we also want to monitor their kidney function. SGLT2 inhibitors, we did go over this, so their kidney function is very important. If the eGFR is greater than 30, dapagliflozin can be started. And if it's greater than 20, empagliflozin is an option. Just, I did mention the SC2 inhibitors are pretty new to heart failure management. And the primary outcome was death from cardiovascular causes. They compared it to placebo, and you could see here there is benefit and it was statistically significant. And also to reduce the hospital admissions, there was a separation of the curves, and we see the benefit here of empagliflozin. And so it has been added to the guidelines for patients with heart failure. Dapagliflozin also. So both of them are used for heart failure. And why did they think this works? There's improved cardiac energy metabolism, decreased inflammation, which does play a significant part in heart failure, the inflammation, decreased cardiac remodeling, and it also reduces reperfusion injury. They found that it also decreased oxidative stress. So these are some of the avenues in which the SGLT2 inhibitors help patients with heart failure. Just a reminder, hydralazine and isosorbide dinitrate was found to be beneficial in patients of African descent, and we do monitor their blood pressure pretty closely. And Avidine, we did go over the criteria, but just to see the starting dose in a patient over 75, 2.5 milligrams twice daily, and in the patient who's less than 75, 5 milligrams twice daily is what's recommended. All right, so we've been following up JD 2 weeks appointment, and then he comes to a 3-week appointment. We've been keeping an eye on his creatinine and his bond and his blood pressure, his heart rate, ensuring he's in sinus rhythm. He has gotten the guideline directed medical therapy, and there has been improvement. You could see he's laughing and looking pretty happy. So he's doing pretty well. And thanks for your help in managing JD during this case. But not all our patients do this well. So for those who do not respond so well, they're here for their 3-month echocardiogram. Guideline directed at 3 months, we should repeat the echocardiogram. They should have been on the medications for the 3 months, the guideline directed medical treatment. And so we're repeating the echo at 3 months. And their ejection fraction is still less than 35%. You ask the patient, have you been taking the medication? So each visit, we should ask about compliance. We should then double check, have they gotten to the target doses of the medications? Have they been compliant with fluid and salt restriction? And is there an underlying arrhythmia? If they have an arrhythmia, this is one factor that prevents them from improving their cardiac function. So we want to assess for that. Also, is there ischemia? Is there coronary artery disease that has not been treated? Did they require angiogram and needing stenting? So we look further in terms of if we are missing the underlying cause, or is there a new cause? Is there worsening in their valvular heart disease? So all of this we'll get from the echocardiogram. So what can we do? Does the patient need valve surgery? Would they benefit from an ICD or CRT? Do they need a left ventricle assist device, or do they need a cardiac transplant? So these are some questions we will ask ourselves at the 3-month visit. So this table we're very familiar with. So here at the 3 months, they says ongoing assessment. Do we need to make additional adjustments to their medication and their treatment overall? And we get the lab work again, the metabolic panel, echocardiogram, and the repeat ECG. And at this point, we are considering whether they need an electrophysiologist referral. Do they need a CRT or ICD? And do they need to see a heart failure specialist? So are they requiring IV inotropes? So this is like, I need help. That's an acronym to help us to decide if the patient needs advanced heart failure specialist here. So IV inotropes, then persistently in NYHA class 3B or 4, and organ dysfunction, the ejection fraction remains less than or equal to 35%. They would have had an ICD from before, and they're getting shocks from the ICD. Several readmissions to the hospital. The edema, despite us titrating loop diuretic, adding on a thiazide diuretic is still quite edematous. Low blood pressure or high heart rate. And because they're hypertensive, maybe we had to drop the dose of the guideline-directed medical therapy options. So this, we do then refer to the heart failure specialist. All right, just a bit about the ICD. It's an implantable cardioverter defibrillator. Class 1A indication if the patient is at risk of sudden death and has had ventricular arrhythmias. And if their ejection fraction is less than or equal to 35%, despite greater than 3 months of optical medical therapy, they remain symptomatic, NYHA class 2 to 3. And we think they should be able to live for longer than 1 year and in good functional status. We refer to the electrophysiologist for ICD. Ischemic heart disease and dilated cardiomyopathy. Those are the disease conditions. And the CRT, cardiac resynchronization therapy, is recommended for symptomatic patients with heart failure who are in sinus rhythm, QRS greater than 150 milliseconds, or they have a left bundle branch block morphology. The ejection fraction is less than or equal to 35% despite optimal medical therapy. We can refer for a CRT, which some patients do benefit quite profoundly from. All right, none of these are available in Antigua, so we have to refer, it is available regionally and internationally. And just a bit on preserved ejection fraction, not much has been available previously. Diuresis, controlling the blood pressure, diabetes, and controlling the blood patient's diabetes. But recently launched at the ESC Congress is Vermatta. So the RNAs, they found are beneficial in the patients with preserved ejection fraction, and also empagliflozin from the Emperor Preserve trial. So I'll go on it a little. So Paragon heart failure trial, these patients were over 50 years. They had symptomatic heart failure, NYHA class 2 and 4. The LVEF was greater than or equal to 45%. They had elevated natriuretic peptides and they had structural disease on the echocardiogram. So 4,000 plus patients, and they were randomized to sacubitril valsartan combination and valsartan only. They followed them for 35 months. So what they noticed, a modest 13% decrease in cardiovascular death or total heart failure hospitalization, but it was not statistically significant. And so that's why it has not gotten onto the guidelines, but they will be evaluating further. There was improved quality of life in these patients. They had improved NYHA class, and there was no effect on death, but decrease in renal events by up to 50%. And they found profound benefit in women and persons of lower range ejection fraction. Now, if you remember, I had said an ejection fraction greater than 50% is what we consider preserved heart failure. Preserved heart failure with ejection fraction. So there were a lot of questions during the presentation of this trial, whether the benefits were due to the patients with the ejection fractions between 45 and 49%. So can we really say that this is only patients with preserved ejection fraction? Well, I know they will be doing further analysis, and we will be getting updates on this one. And empagliflozin in heart failure with a preserved ejection fraction. This is a SGLT2 inhibitor, and these patients, the ejection fraction was greater than 40%. 10 milligrams once daily of empagliflozin was used. And what they found that there was a reduced combined risk of cardiovascular death or heart failure, hospitalizations for heart failure, and regardless of whether the patient had diabetes or not. But if you note again, the ejection fraction was more than 40% and not greater than 50%. So still a bit clouded, but there was great excitement about these two medications. They think with further analysis, we should be able to probably recommend one of these medications for patients with heart failure with preserved ejection fraction. So just to summarize, heart failure results from a complex interplay among genetic, neurohormonal, inflammatory, and biochemical changes that act on the cardiac myocytes, the cardiac interstitium, and the heart overall. Despite evidence-based management and modern drugs, devices, and surgery, many patients still have a poor prognosis. And early, appropriate, and aggressive management of risk factors is key. Prevention, better than cure. We are promoting this. Heart failure in Antigua, a lot of it is due to hypertension. A lot of it is due to non-compliance with medications. And so we want to do the preventative education from the preventative standpoint. Lifestyle modifications provide the backbone with the addition of, as we went through, the RNAs, ACE inhibitors / ARB, beta blockers, the SGLT2 inhibitors, the MRAs, and ICD CRT treatment and surgeries. And so we look forward to what the final consensus is on treatment of patients with heart failure with preserved ejection fraction. And so I'd like to thank you for helping JD get better. And I hope you benefited from this talk, aware of the new options, aware of the new medications that have been added onto the formulary for patients with heart failure. Thank you.
Thank you very much, Dr. Meade. We were happy to help you with your patient today. We do have a few questions already coming in the chat, and I would just like to read them for you one by one. Somebody is asking, under what conditions should any patients be treated with ACE inhibitors and ARBs concurrently?
That is not indicated at any time. That is harmful for the patient. Probably it was a bit confusing. It's either or. So it's either the ACE inhibitor or the ARB. So that's never an option of using both of the medications.
Thank you. The second question would be, how do patients with diabetes respond to Vermatta compared to non-diabetics? Right.
As far as my research, they have not researched it comparing the diabetic versus a non-diabetic. It's been a general population, and each population has benefited significantly.
And thank you, Doc. And the third question that has been posted in the chat would be, what are the most common adverse events with Vermatta in your patients?
The challenge has been the blood pressure, and so they may become hypotensive. So you start at the lowest dose. So that's what I've been doing, starting at the 50 milligrams twice daily. There's a few patients who've actually gotten onto 100 milligrams twice daily, and one patient in particular on the 200. So as you know, many patients, their blood pressures starting out, do not give you the room to up titrate. And so hypotension would be one. The AKI, acute kidney injury, not so much. I can't necessarily blame it on the Vermatta because we know it's part of the physiology of the patient with heart failure. And many do develop acute kidney injury. So all in all, it has been the hypertension and the inability to titrate. But is it due to the Vermatta or the reduced systolic function? So it has been well tolerated, honestly. I haven't had anyone with angioedema. The chronic cough, no, because it's valsartan and less likely. So it honestly has been pretty well tolerated. by the patients who started on it.
Thank you, Dr. Meade. For those of you not monitoring the chat, Dr. Thomas also contributed that we also have metolazone, torsemide, and eplerenone available as, I believe, diuretics. And we also do have empagliflozin available for the heart failure management. Are there any more questions that people want to pose themselves? Okay, somebody's asking metoprolol versus bisoprolol. What factors would guide your selection?
So well, both of them have shown great benefit in the patient with heart failure. Both of them are once daily, but the bisoprolol allows you to start at a lower dose. So in the patient you're worried about bradycardia, you could start with the bisoprolol. They're not equivalent. So the lowest dose for the metaprolol is not equivalent to the lowest dose for the bisoprolol. So the patient so bradycardia would be one concern, and the ability to start at the lowest dose and up titrate, I'll go with the bisoprolol. But in terms of benefits with regards to improvement in cardiac function, both of them are pretty useful.
So thank you. From a formulary perspective, we had included bisoprolol for use in the elderly, as well as for people with more advanced pulmonary complications that might have required a more selective drug. So that was our thinking, to give it a little wider application. Thank you for your answer. Dr. Kenneth Connell is asking, what is the role of cardiac rehabilitation in heart failure?
It is beneficial, used primarily in the patient with ischemic heart disease. But if we want to help with the functional status of our patients and have them do it in a monitored environment, guided by the rehabilitation specialists, I would say many of them, because once they hear they have a heart failure, they're hesitant to exercise. And so they would get guided exercise. Their functional status would improve. They'll be more confident. There's also an education and nutrition component. So it's from several angles. They will benefit the patient with heart failure from cardiac rehabilitation.
So thank you, Dr. Connell, for the question, and Dr. Meade for the answer. Dr. Dawood is also asking if there's any role for calcium channel blockers in the management of heart failure.
It is not on the guidelines in the patient. So it's not one of the guideline-directed medical treatment options, but in the patients with hypertension, and if this we think is contributing to their heart failure, that's the avenue we will use the calcium channel blockers, amlodipine, for example. But it is not one of the guideline-directed medical treatment options.
Thank you. What is your take on patients being switched to Vermatta by a general practitioner or the specialist?
Well, you're benefiting from these talks. I think the more we're able to educate and guide the treatment of these patients, but I would think because there are several factors that need to be monitored, it is best if the internal medicine specialist and the cardiologist manage these patients. We are monitoring from various angles their underlying comorbidities. So it is best to refer the patient to the internal medicine specialist or the cardiologist. And when it arises for the need to referral to more advanced centers, we are the ones who ideally should be making these decisions.
Thank you. So I believe currently it is under SAD forms. It will require approval, and I think requests coming from internists and cardiologists are going to be given priority at this stage for the safety of the patients. But maybe it could be that they are maintained under Vermatta by a general practitioner. Okay, thank you. We have another question for the benefit of the participants. Where does Atenolol fit into heart failure treatment? If not, then why?
Right, I did list the guideline-directed beta blockers. These medications were studied in patients with heart failure, and they were beneficial in the patient with heart failure. So we want to use the medications that have been guideline directed and recommended. These, as a reminder, it's Carvedilol, Metaprolol, and Bisoprol.
Thank you, Dr. Meade. Just on a side, I just want to say that we feel very honored that we have as many as 93 participants on this call today. We feel that we're helping to share the word for what we have tried to achieve with the medical benefits formulary here in Antigua. But as a reminder to all, the talks will also be available on Medical Benefit Scheme's YouTube channel, which you must go to now, hit like and subscribe, and follow them closely for all further updates that they might have. Just waiting a few more seconds to see if there are any questions coming from the floor still. We agree that we can, one more question. I'm not seeing it. Okay. Fantastic question. Should Voltaren and prednisolone be taken when taking any of these medications? Can they cause heart failure?
Thank you for that question. And, you know, the NSAIDs, patients who are on NSAIDs, of which Voltaren is one of them, we should avoid them. They cause sodium retention and therefore can push the patient into a heart failure exacerbation. So it's one of the medications we avoid in the patient with heart failure. Prednisone can have a similar effect, but they would need to be followed by the cardiologist and the rheumatologist or the oncologist. There are a vast group of patients who use it. But it's a challenge because, for example, in the patient with a rheumatic, with lupus, they need their prednisone, but then they develop heart failure. And this is where it comes in terms of the experts monitoring these patients. We start at the lowest dose, we titrate, but we do it with great hesitancy. It's not something you want to just put them on prednisone and they go on their way. And this is where the specialists come in terms of monitoring these patients. So the NSAIDs, no, we avoid it very much. Prednisone, similar, but there's some situations that we cannot get around it and monitoring is required. So Panadol is what I use, the acetaminophen for mild pain. Cocodamol is an option for more severe pain. That would be my recommendation.
Thank you very much, Dr. Meade. And thank the audience too for their participation by submitting quite so many questions. I think we're off to a fine start, reminding you that we will convene again in 2 weeks' time to speak about management of diabetes and the management of bronchial asthma. But for now, hold on to your seats because we have none other than soon-to-be Professor Dr. Kenneth Connell presenting for us. It is indeed my privilege and pleasure to introduce him today. He's the Deputy Dean for Internationalization and Recruitment in the Faculty of Medical Sciences, the University of the West Indies, and he's also a lecturer in clinical pharmacology. He's a member of the University West Indies Senate, which is the highest decision-making committee of the University of the West Indies, and a public orator for the University of the West Indies. He's also the chairman of the Barbados Drug Formulary Committee and a consultant to the USA Center of Disease Control and Prevention. He's the director of the Healthy Caribbean Coalition. He's the former or exiting governor of the American College of Physicians Caribbean chapter. And of course, he's a consultant internist at the Queen Elizabeth Hospital in Barbados. I could think of no other person more suited to present to us today. Oh, before I say that, I just want to acknowledge Dr. Connell's contribution also in our redesign of the formulary with regards to the cardiovascular drugs and the hypertension drugs. So therefore, there's no other better person better to present for us now updates in the management of hypertension. Thank you, Dr. Connell.
Well, thank you so much, Dr. Cordner. Can you hear me clearly? And let me start by first acknowledging the presence of your Governor General, Sir Rodney Williams. Thank you so much for joining us. And it is a pleasure being here with you, albeit virtually in Antigua and Barbuda. I think this was a fantastic meeting so far. Dr. Meade, congratulations on the Heart Foundation of Antigua, and that was my plug for cardiac rehabilitation in your center. And it's also great to see in the audience some of my past students, Dr. Hall and Prescott. Now that I've put them on the spot, they're going to be slightly embarrassed. But it's great to see them here in the audience as well. So I'm going to get started, and I hope that by the end of this presentation, I will convince you that hypertension still is a problem, despite being in the middle of a global pandemic, which is causing so many lives. I also hope that I would convince you that your formulary is, as I said privately in the chat to Mr. Lovell and Dr. Cordner, is excellent and is really a representation of best practice now by the WHO and in terms of their hypertension guidelines, which were only released about 2 weeks ago. So our whole world has really been focused on one thing, that's wearing a mask, social distancing, getting vaccinated, and looking at all these lives that are being lost from a novel virus, COVID-19. And I suppose even in Antigua, the Caribbean, the rest of the world, many of us on this call are familiar with people who have become ill or even who have passed. Even in our own fraternity, we have had many of our colleagues who have succumbed to this illness and who are still on the front lines battling COVID-19. It has cost us a tally of 4.5 million lives in the last 21 months, just about. And that's significant, and it's not something that we should understate. Cardiovascular diseases, however, in just 1 year have also costed us 17.5 million. Can you imagine that? There is no flashing counter on CNN saying every time someone dies of a heart attack or a stroke or heart failure. But when you think about it, you know, more than 3 times, almost 4 times the amount of people who have died from COVID-19 are dying from cardiovascular disease. And it is for this reason that we just can't forget about it, even as we focus on a pandemic. Ischemic heart disease accounts for just about 8.5 million deaths. In 2019, it did at least per year. And if you look here carefully, you can see we haven't done much better in improving it in 2 decades. So in 2020, in 2000, it was just about 6.5 million. The leading causes of death, therefore, are still ischemic heart disease and stroke, and then COPDs and some of the other respiratory illnesses follow after that. And so because of this urgency, and I want to really drive that home, it is an urgency. It's not an infectious disease, but it's claiming a lot more lives. There was a call to action somewhere in 2015, started by CDC, the United States Center for Disease Control, and the World Health Organization, where they sat and they decided in a meeting in Miami, Florida, to come up with these packages to reverse the cardiovascular disease pandemic that was occurring globally and claiming so many lives. Although I'm going to concentrate today on just one of these packages because it's really to you, the healthcare professional, I want you to bear in mind at a national level in Antigua to start thinking about interventions that will decrease population risk factors, such as ACTIVE, which looks at physical activity, Empower to get your population to stop smoking, reverse policies at a national level, SHAKE in terms of salt reduction, again, these are national policies, and replace trans fats in foods that are sold in your supermarkets and on the shelves. And I'm also going to put a plug in here for front of package labeling so that you have an understanding of what you're actually consuming. But more specific to this talk is HEARTS, H-E-A-R-T-S. The H standing for Healthy Lifestyle Counseling, and the E, the evidence-based treatment protocols. And I'm only going to focus on these 2 today because of the audience, but I also want you to know, again, because of the audience, that the A and the other packages are also very important. Access to essential medicines and technology. I mean, this discussion would be completely academic if your formulary committee did not have these drugs available for you to use in tomorrow's practice. Team-based care is also important. How do you reshift care and reshift skills that are used in the management of hypertension, especially since some of your doctors are now on the front line battling a pandemic? How do you reshift care so that pharmacists may have a bit more to do, and also nurses as well? And of course, systems for monitoring are also important. This is where technology comes in, and there's an entire implementation guide for hearts at the national level as well. And it's really all to address this whole 1/3 reduction, sustainable development goal number 3.4, a third reduction of NCDs by the year 2025. And we are way behind that and off target for attaining that goal. And so many more lives on the current trajectory will be lost from cardiovascular diseases. And this slide really just highlights that as well. But how has the pandemic really affected cardiovascular disease management, and in particular hypertension? We'll look at what are the services that were disrupted initially in this pandemic. And these data are from the Pan American Heart Association branch of WHO, looking at services throughout our region. Rehab services, such as the ones in Barbados and in Antigua and Barbuda, they were stopped because it was a gym-like environment. It wasn't considered an essential service. And so our cardiac rehab patients that were coming 2 and 3 times a week at the Heart Foundation of Barbados suddenly stopped. And then what happened weeks and months later, they presented to the emergency room in heart failure because cardiac rehabilitation was stopped. The access to medication was more difficult. No one wanted to come near a hospital because of a fear of getting COVID. So the health system struggled, not because of the number of COVID-19 cases, but the cardiovascular cases for which management was stopped. And hypertension clinic is the second here, our hypertension management. I have to admit, even as a person in charge of the resistant hypertension clinic, we went virtually in probably a month into the pandemic. We still have a hybrid clinic where many patients are seen by telemedicine. Some patients actually prefer this. It does have its advantages, and I would like to convince some of the clinicians on the line, because I was one of the clinicians that was very much against telemedicine. It has a role in medicine. For instance, you don't get the excuse, I forgot my medication at home, because they are at home, or I don't have my diary with me. You get to kind of cross-check information with relatives, and the cook in the family may actually be in the background on the call, so you get to address things like salt reduction and smoking cessation. So those are kind of some of the quick pointers or advantages to telemedicine, but suffice to say, this isn't ideal. I mean, you can't examine patients, you can't assess them thoroughly, and therefore your diagnosis may be very skewed, and also your management. But if I'm putting it to you that even if you had a standardized treatment algorithm that you, the patient, the pharmacist are all on the same page, you're speaking the same language, so that if you have to titrate drugs or move to the next step in your algorithm, everyone can more or less understand what the goals are. So it's really time to invest in the disruption of NCD services in the context of COVID-19. We are probably not going to return to normal. And our goal is therefore going to have to be, how do you get back to managing these conditions remotely or with novel interventions so that these patients do not succumb to both mortality and morbidity? The heart failure admission rates, and Dr. Meade may be interested in this, at the Queen Elizabeth Hospital have gone up by almost 250%. That's significant. Most of the house staff at night are spending their time managing heart failure. And if you took a more in-depth look at why this has happened, these are people who have been rationalizing their medication, rationing their medication, such as their hypertension drugs, their diabetes drugs, their heart failure drugs, because they don't want to come near a hospital where there's a fear of getting an infectious disease. And the same thing has happened in primary care. I got a call from one of my most obsessive patients who said, I know my appointment is coming up, but I really am terrified to come into a GP's practice or any practice right now because of the fear of COVID-19. How can we do this remotely so that I can get safe care And then of course we had a consultation on telemedicine, but there's that fear out there. So believe you me that some of your patients don't want to see you face to face. There are gaps in hypertension management. And as much as we say this over and over and over, you know, we really do have to face this. Lots of new drugs are out there for the management of heart failure. And of course, hypertension, we have rationalized cure as well. But you can only treat people who actually know they're hypertensive. And they're only going to know if they're hypertensive if you are screening them. Do we screen people enough? It's estimated that only 54% of people with hypertension are actually diagnosed. One of the questions we asked the primary care docs in 2016 in an NCD clinic in Barbados was, how many of you are screening patients, sorry, in a non-NCD clinic, how many of you are screening patients for elevated blood pressures? And the number was shocking, 23%. In other words, if you went to one of our primary care docs in this clinic for anything, immunization, you know, you stumped your toe, whatever, you weren't getting your blood pressure checked. Yet we are in a region where the prevalence of hypertension or elevated blood pressure is so high, and opportunistic screening is lost. So 42% of people who are diagnosed with hypertension are actually treated. So even though we get it right in diagnosing them, we still aren't aggressively treating them. And this isn't only just our patient's fault. I know we like to say all the time, oh, it's the patients that aren't taking the medication, but sometimes with the healthcare providing team, we aren't starting them on medication. And even if you started them, we aren't titrating their doses either. And only 21% of those who are treated actually have it under control. Now, this actually shocked, and I have a slide on this that I showed my residents. When you get closer to your control in clinic, when the patient gets closer to control, there is significant physician inertia. We don't want to touch drugs, especially in younger patients. We keep saying, go have less salt, do some more exercise, you can drop a few pounds more. I'm going to leave your medication as is. And so these patients who are close to target remain just that, close to target. They never reach target. And that's because of physician inertia. And so the WHO has come up with guidelines on how to manage. I'm trying to get my camera out the way so that I can actually see the rest of the slide. It's one of the problems with Zoom. Okay, closing the gaps. How do you save lives and close the gaps? First of all, continue to prevent modifying risk factors. Anytime you see a patient in your pharmacy, in your practice, congratulate them about not smoking and encourage them to stop smoking if they are smoking. Try to get them to cut salt. Don't tell them, you know, that you're supposed to consume 1.5 grams of sodium in 24 hours. No one knows what that is. Give them practical hints. Do not lemon salt your meat and fish. Try not to add any salt to your food. Try not to have as much fast food, and congratulate them every time they do something successful. In Barbados, the Saturday pastime food is pudding and sauce. And so I kind of negotiate with my patients. You will only have pudding and sauce on one Saturday a month because they're not going to give it up completely. You know, it's loaded in sodium, and it really does make a difference if they can make micro steps. Write them an exercise prescription so that they know exactly how much exercise you want them to do, and congratulate them when they meet half that goal and try to get them to maybe a little higher. So closing the treatment gap is also important. Standardized algorithms help this. Improved procurement certainly helps this. I know your procurement facility is going to enjoy your new formulary because there are lots of combination drugs in there, which makes it easier to order drugs. It also makes it easier to prescribe drugs. And it also makes it easier to manage hypertension remotely, because you can say things to patients like, instead of taking one tablet or half a tablet, take the whole tablet. You don't even have to change the prescription because they understand the algorithm that you're following. So in conclusion for this section, I hope that I've convinced you that cardiovascular diseases are still a leading cause of death, even in the middle of a pandemic. New guidelines provide protocols based diagnosis, treatment, and control, and they supplement the existing work that all of us are doing. So now is really the time to act. in order to reverse the Sustainable Development Goal 3.4, we need to act now. And unfortunately, there's no quick fix, such as a vaccine, which has proven to be a difficult fix even for a pandemic. So let me introduce HEARTS to you now. And the objective of this section is really to review the purpose of HEARTS, explore some logistics of the healthy lifestyle, which I think that you should kind of, again, partition in your consultation. Every time I say consultation, I don't necessarily mean a medical consultation. The 5-minute consult that patients have with their pharmacist is also important. And it's not just to dispense drugs, but it may also be for you to give some structured information. So the HEARTS package looks at simple things to improve blood pressure control. One is the widespread availability of drugs, which I congratulate you already, have on your formulary. Improve systems for the delivery of care. There's some things in our health system that we just don't get right. For instance, last Thursday in the hypertension clinic at our hospital, I realized that several of our doctors are just sitting there waiting on patients to come in, whereas several patients are outside waiting to be screened. And therefore there's a gap in care because they're getting their temperature check or they're filling in information. And that's not efficient, because then we're just sitting there having an academic discussion when we should be seeing patients. Or for instance, what about in your own practice? We asked a group of doctors and nurses, how many of you think that your nurses are doing enough in the management of hypertension? And the nurses all said, well, we don't think we're doing enough. We think we can do a lot more. We basically just do a blood pressure. We really don't give a lot of education to patients. We write it in the note. The doctor is going to recheck the blood pressure anyway, so why are we even doing it? And when we asked the doctors, do you think your nurses are doing enough? The doctors said, we think our nurses are overworked. They're doing too much. We really wish we could do more. So how do you kind of get the team-based care coordinated? I'll use an example of my clinic. In my clinic, for instance, I don't do blood pressures at all. The nurses do blood pressures, and more importantly, the nurses are checking the out-of-office pressures, which are going to be pretty important, as you'll see. This could either be a diary, so patients always come in with their diary. The most common excuse is, I forgot my diary at home. There's also a subliminal message sent to patients because they know that if they don't have their blood pressure diary, we're not going to alter medication based on clinic readings, so it's going to delay their care. And more than likely, the nurse is going to give them a rescheduled appointment in any case. So our adherence to walking with your diary is 96% now. Everyone's going to come with their diary. And the second thing is everyone's also going to come with their medication. We want to cross-check which drugs have been dispensed. How are they taking them? Are they remembering to take it at night? How are they recording their pulse and not just their blood pressure? These are some practical tips that you should consider in your clinic in task sharing. I'll even be even more extreme than that. So the same security guard outside of the hypertension clinic that's screening patients come in with the temperature gun, which all security guards now take literally as a gun. So he's also asking, remember, the doctor is going to ask you for your diary. So be sure to have your diary ready when you enter the clinic. So from the time the patient enters the hospital environment, they're inundated with information about the visit. The pharmacist is going to close the visit by saying, so remember, reduce your salt, try not to add any sodium, remember to cut the chocolates and bread out your diet as well, all trying to reinforce things. So we're all basically on the same hymn sheet. I can't believe I've used a religious analogy, but anyway. So the cascade of treatment, you have first the detection and diagnosis of persons with hypertension. We agree that's a problem. So mass screening, even in COVID, we did the virtual May measurement month. It was kind of fun. We got patients to do their blood pressure at home and then do the blood pressure of a neighbor or someone in their bubble, of course. And we asked them to kind of send it into a center. So we still got national data on blood pressure, and it raised awareness. Some people who never used a blood pressure device, get younger people involved in encouraging and pressuring their parents. You really do need to take your blood pressure, buy a blood pressure device. And guess what? For patients living with diabetes, although many formulary committees like ours provide them with blood glucose monitoring, the determinant of death in diabetes is actually blood pressure control. So again, we've now changed that. Patients living with diabetes get a blood pressure monitor. and they have to pay then for the blood glucose strips, because unless they're on insulin, we really don't care if they're monitoring their home blood glucose. We just do an HbA1c every 3 to 6 months, and that's how we manage them for diabetes off insulin. On insulin, of course, it's different. So here are some simple things that you might try to do in the clinic. Since there's a cascade, this is a medical conference, and again, we're just focusing on risk factors, high blood pressure, obesity, diabetes, but this isn't where it has started. It hasn't even started with behavioral risk factors, like an unhealthy diet, tobacco, physical inactivity. I want you as healthcare providers to also lobby for things like green spaces and access to essential medicines, access to cheap foods, for instance, access to programs that will allow people to work from home and to have a better work-life balance. All those are kind of things that will eventually feed into the end determinants here, which is what we're seeing, heart attacks and stroke. So your unhealthy diet, it's no secret. Everyone knows what a healthy diet should look like. And you might have this image somewhere in your practice to guilt your patients into thinking, look, your plate, at least half of it should look like this. You should have some colors there in terms of portion sizes. I actually write this on a dietary, well, part of a dietary, a lifestyle prescription. I write out exactly, so 3 days a week, you're gonna have a healthy diet. It's gonna comprise of at least these portions of food. You're gonna have your 5 a day, those kind of things written on a prescription. And here's the way you're gonna cut, here are ways you're gonna cut salt. Putting themselves only on one Saturday of the month. I know I can't ask you to give up completely, but only on one Saturday. I also want you do not lemon salt your meat. I can't do it without lemon salt my meat. Okay, you can lemon salt your meat only on Sundays. Every other day, no lemon salt. No fast food. I can't do without fast food. KFC is right next to my office. Okay, you can have KFC on Fridays. But if you have KFC, you can't have after-work drinks because that's harmful use of alcohol. So we have to negotiate a trade-off. Either you're going to go for drinks or you're going to have KFC. You can't do both. And amazingly, having these conversations, I know that nurses, and my hat's off to my nurse because she does most of this stuff, sitting and having these difficult conversations with your prescription, your lifestyle prescription, takes a lot of effort. What about physical inactivity? So don't just sit there and say, you know, you need to do 150 minutes a week with your target heart rate up to 80%, because no one, not even medics, really get that. So give them practical things to do. For instance, walk around the savannah, or in Barbados, I say the garrison. If you walk around the garrison savannah, walk at a pace that you cannot speak to your husband because you're so breathless, okay? Most of the ladies tell me, I don't mind not speaking to my husband when I'm walking in any case. So, but walk until you're breathless. It's not just a casual stroll. Once you finish your exercise, do not stop by the ice cream cart that is strategically positioned around the garrison, because that defeats the purpose, right? So make sure that you're getting your physical activity in, but have water after your physical activity. Tobacco use is next. Now, here's what I do to actually get patients to stop their tobacco use. I'll skip to the next slide. Convince them how much money they're spending on cigarettes. Calculate it in the office. The number of cigarettes in a pack a person smokes per year, the number of years you've been smoking, the average price of a pack of cigarettes, all this expensive food. Oh, the government in Antigua, the food is too expensive. I can't buy healthy food. Look at all the money you're spending on tobacco. Imagine if that was spent on buying healthy food. And of course, the harmful use of alcohol. The American Cancer Society now recommends that there is no safe use or safe dose or safe amount of alcohol. This is kind of hard to sell to Caribbean people, but you might often advise patients of ways to reduce their alcohol consumption. And don't just take, I only have a drink socially as a cop-out. How often do you socialize? 3-4 times a day, that kind of thing. So kind of figure out exactly how much alcohol that they're consuming. So this one is really for the residents. Motivational interviewing is quite topical now in internal medicine. They've actually mapped in terms of an intervention how much it impacts on outcomes. Don't ask me why this is the case, but it seems to impact systolic blood pressure a lot more than diastolic. It does impact obesity, and weight reduction, as well as diabetes glycemic control measured by HbA1c. So I would advise you to use the motivational interviewing, but unless you're a family care doctor and not a busy hospital doctor seeing several patients in your clinic, my family care doctors love to drill motivational interviewing because they get to sit back and really have a conversation with patients. And I tell them, I can't do that. I have too many patients to see. And they say, well, okay, well, try this short intervention. So here's a 5A approach to how you might have a brief intervention. This should not take you more than 5 minutes in your clinic. So the first thing to do is to ask. You have to ask patients, ask about the problem. And is it relevant to the visit? Ask it in a friendly way, without being judgmental. Don't make statements like, so you don't smoke, right? Because smoking is bad for you. Just allow them to give them the information. Keep the questions simple. Don't ask patient things like, how many pack years? What's a pack year? I mean, the average medical student doesn't know what a pack year is. Hopefully not a UE one, but a non-UE medical student. But even if you're asking patients, make sure that it's very simple language. How are you coping with the added salt in your diet? Don't say how much sodium. One guy said to me, I don't consume sodium because sodium is in all these drugs. I see the tablets, they have sodium, this, salts. The only thing I have is pot salt, because that's what he knows. He knows pot salt. He knows pink Himalayan salt because it's fancy and he thinks that it's healthier. So use simple terms. Healthcare professionals, we have an obligation to advise patients that an intervention or a lifestyle is unhealthy. So don't just record that they are taking more salt, but advise them, or do you know that salt could have an impact on your blood pressure, or you should consider salt reduction. So a person, make it specific. A person with hypertension, you might talk about salt reduction. If they have young children, you might say, for instance, secondhand smoke and the effects on your kids, those kind of things. Assess the patient's readiness to start making a change by asking 2 questions. Okay, are you ready to have a diet that includes more healthy options? The answer to that might actually be no. I mean, most patients are kind of going to lie to you in any case and say, well, yeah, I am ready. So take that as your signal to say, well, okay, here are some steps that we can do to now get you to the next level. Don't assume that the person in front of you even thinks that they're overweight or obese. One lady, I said to her, I said, well, so the last time we discussed your weight, and you said that you were going to take some steps to lose some weight, and she came back and said to me, well, my husband said to me, my weight is just fine. And so then we had to discuss, well, why the weight gain was affecting her blood pressure control significantly and her diabetes control. Healthcare professionals should also assist patients. Once you've assessed them, don't just leave them there. Provide basic information, identify sites, allow them to go onto apps like the WHO Healthy Lifestyle app, ways of coping with trigger situations. For instance, if you're a bartender, it's kind of difficult for you to reduce your harmful use of alcohol. So how are you going to give that bartender some tips in his own job? Make it very practical. So every time someone offers you a drink, have a drink of water. No one needs to know what's in your glass of water with ice, right? I mean, that could be anything like vodka, gin, it could be anything. I do that quite often as well. So have your glass of water, because people are going to offer you drinks, okay? And then, of course, arrange for support. Don't assume that once they have left the holy office that they're going to go in peace to love and be healthy forevermore. They're not. They're going to slip into the real world. They're going to pass the KFC, which coincidentally is located right next to my hypertension clinic. And they're going to stay up by the bus stop and say, you know what, it's hot. 2 Cokes aren't going to kill me, right? And I just can't go and order a Coke, so I might as well have at least 2 pieces of chicken to go with it. So you need to give them practical hints on how they're going to cope in the real world with follow-up calls and all those kind of things. So the take-home message really is, doctors, nurses, pharmacists, this is an important conversation. Healthy lifestyle is not just a tick box that you do as the patient enters, or even more ridiculously as they leave. And you've given them a prescription of 20 tablets. So don't remember, I want you to have a healthy lifestyle as well. They say, yeah, doc, I'm trying to live healthy. what does that mean to them, and what does it mean to you? You've kind of just ticked a box. I have to admit, when using my EMR, I was guilty of this as well, to just tick the healthy lifestyle box as well. Now let's move on to how do you diagnose hypertension, because this is a problem. First of all, screen everyone. Every adult patient that you see that's alive needs to have a blood pressure done. There's no excuse, whether they're coming to you for a headache, whether they're coming to you for an insurance medical, they stub their toe for a PCR test. Interestingly, in Barbados, I had a conversation 2 weeks ago with the testing team. I said, look, you have a captive audience. People are coming to you to get PCR testing. Do their blood pressure. Why not just put a cuff on and do their blood pressure? They're sitting in the chair to have their swab done, check their blood pressure, and you'd be surprised how many people they've picked up with elevated blood pressures as a result of that. Opportunistic screening is not only for infectious diseases, but also for non-communicable diseases like hypertension. And we all go through this checklist, right? We all go through this checklist with our patients. We say to them, okay, so don't have caffeine and exercise before you do your pressures at home. Make sure that you've voided and you're sitting comfortably in a quiet place. I tell my patients, know what your blood pressure chair is at home. Sit in it, make sure it has some armrests that you can rest your arm. Make sure that you are in the seated position with your feet, your ankles and your knees uncrossed, and that you're applying the cuff onto your bare arm. I don't really make a big deal about this anymore. The new devices by Omron can be applied over light clothing. They have the IntelliSense technology. So, you know, if that's going to be a barrier and say, well, you know, doc, I didn't want to take my shirt off, so I didn't take the blood pressure. That's no longer an excuse, okay? Of course, you probably don't want to record these readings when you're under extreme stress or pain either. Get them to write down the readings. It doesn't have to be a sophisticated app, although an app is cool, and I know the younger docs like Dr. Hall and Prescott would encourage this. But writing on a piece of paper is just as effective. And of course, once they've written it, they have to bring the diary. It makes no sense that they've done this work and they bring the diary. Now, here's the last step. Once they've brought the diary to your practice, you can't ignore it. You can't then say to them, you've done your blood pressure. Say, yes, doc, I have all the readings here. And you just say, oh, okay, so let me check it here in the office, because that's sending the wrong message. Go through the diary with them, congratulate them on taking the readings. I have to say, I get suspicious of some of my patients that all of the readings for the last week before the visit are all 120 on 80. And I can kind of look outside and see that they're just rushing to write stuff down in the car. But at least tell them, you know, I really want to congratulate you that you have very consistent readings. It's unusual to have such consistent readings, but, you know, remember, the validity of what you're given here is really affecting the quality of care that I can give you. So it's really important that these readings are accurate, and of course that they're truthful as well. And so you send a subliminal message to them, do not cheat with your readings. Of course, you could also use devices that I use in my private practice, which are iHealth technology. They wear the blood pressure cuff. It comes through to a dashboard near you, and you get to see what their blood pressures are doing. It removes the anxiety of, I'm going to forget the diary, or I had a one-off reading. So someone might have a 160 on 100, but they're not going to panic because they know that I'm looking at the trend of readings and not necessarily the individual reading. So here's a schematic. I usually WhatsApp this, or my clinic does, to patients so they know exactly, and I get really obsessive about it. Those of you who are familiar with the OSCE system of examination, we do the same OSCE with our patients. We actually sit and watch them, and we point out all the points that they've missed. Okay, so you did everything well, everything was perfect, but when I asked you if you were comfortable, you said, yeah, I'm okay, which means you spoke during the reading. So do not speak during the reading. So all those kind of things patients can really get better at. So there's so many guidelines out there, and I'm not going to go through which one you should use or not use. Suffice to say, I think WHO has done a reasonable job at standardizing this and not being too obsessive about it. The only thing I do want to say, however, is that your office blood pressures are higher, and most of the guidelines speak to 140 or 90. This is really representing office readings. Your home reading equivalent is probably more the equivalent of 130 on 85. So your office 140 on 90 is more 130 on 85 at home. So you have to interpret your home readings I almost said with a pinch of salt, but not with a pinch of salt, because it's not the same. It's not the same equivalent to the office. And this is something to bear in mind when you're reading clinical studies. They're really speaking of office readings unless they say so explicitly that they're out of office. Someone's on this call is going to ask me, well, what about 24-hour monitoring? I very rarely do 24-hour monitoring now, and I can almost list when I'm going to do it. Well, I do it a lot more in healthcare providers like colleagues, because we have reverse white coat hypertension. So you're in the office, blood pressure is normal, they're chatting with me about how frustrated they are about patients not taking their medication. They're totally relaxed about it. And I do a 24-hour monitor on them. And you might ask, like, what is the red flag? Well, they have a displaced apex beat, or they have signs of hypertensive retinopathy that it just does not add up with the blood pressures in the office. So I check the blood pressure in 24-hour monitor and it's elevated. Mask hypertension, of course, needs to be treated because we don't live in an office, and our blood pressures should be treated if we have mask. So that's a learning point for healthcare providers. As we see our colleagues, always bear in mind mask hypertension, and either get a 24-hour monitor on them or ask them to do home readings when they're in their usual home environment and have a look at them. Everyone else, I kind of just use their home readings. There are a few circumstances where I am kind of unusually dosing medication and splitting drugs, and I want to look at 24-hour control and 24-hour nocturnal dipping of blood pressure. Then I do a 24-hour ABPM as well. So here's some of the evidence-based guidelines. And remember, I started off by saying that we always blame everything on the poor patient. I was hoping there might be a patient advocate on this call, but there isn't. But the poor patient has to deal with this. You're just not taking the medication. That's why you're not controlled. Poor adherence with the patient is kind of the #1 thing for physicians, but it's actually not the #1 determinant of control. Now, look at all these factors that fall under healthcare provider, not patient. So raised blood pressure, we always say, is just white coat. My colleagues in surgery, they love to tell me, oh, the blood pressure is 200 on 100, but it's just white coat. Anyone that can get their white coat up to 200 on 100, even if the white coat was removed, trust me, that blood pressure is going to be elevated. We also are reluctant to treat an asymptomatic condition. About 4 years ago, I was diagnosed with gout because it's familial, not because of my unhealthy lifestyle. But the one thing I will never forget to take is my allopurinol, because I never want another gout attack. It is the worst thing. I cannot ascribe it as being worse than childbirth, but I do have some female patients who've said it is worse than childbirth. It is horrifying, but an asymptomatic condition isn't. So you're probably going to forget to take your blood pressure medication if you aren't really getting any pain from elevated blood pressure until it's too late. There's also a lack of adequate time with patients. Everywhere around the world, we don't have enough time. And there's therapeutic inertia. Remember, I spoke about physicians not titrating meds. I think I have this in another slide. And of course, there's lack of adherence to treatment guidelines. We did a poll in Barbados in primary care. We asked doctors, how many of you are following a hypertension guideline? 97% of them said yes. And then when we asked them to list which hypertension guideline you're following, they couldn't, because they're actually not following. They just have a guideline in their office, and they know, what was the last one that came out? As one person said to me, JNC4. So you have that in your mind, I'm following something, but you're not. And interestingly, data from the United States suggests that what we are following is a lot of aggressive marketing from drug companies. It's no surprise that one of the most marketed drugs in our regions it's an ARB, and it has blue, red, and white on its box, is heavily marketed. It's one of the most expensive drugs in our healthcare system, and it's used as first-line treatment. Yet we know in our Black population, it's not the most effective as a first-line drug. So we think that the subliminal messages of the pens and the free lunches and stuff aren't working, but they really are. And of course, our health system sometimes is at fault. We have inappropriate follow-up. I should tell Dr. Meade that the follow-up time for patients in the heart failure clinic is anywhere between 9 months to a year. I mean, what kind of follow-up is that for heart failure? If if there was no way of doing this remotely, like getting patients to do their weight and sending in weight diaries and Lasix clinics where they can come in and have IV diuretics every 3 months or so, or even getting them to self-titrate their diuretic medication, or sending in pulse rates and titrating their beta blocker, those kind of things. We could not manage heart failure every 9 months in a healthcare system. This is the graph I really want to leave with physicians, because this is really us, right? As you move, we ask how the percentage of visits without a medication intensification. Without, look, when you are closer to target, so just 150 to 159, I mean, that's not too far off. You're almost tempted to say, okay, just cut back a little on the salt fish and you're almost there. We don't change the medication, and these people remain at 150 to 159, whereas if the blood pressure is more than 180, then the percentage of patients that without a medication change falls significantly, because that's a red flag for us, and we want to do something. These are the only drugs I'm going to concentrate on, because I think we appreciate that the beta blockers, as described by Dr. Meade previously, I'm glad you handled the Atenolol question. It wasn't posed to me, but they have been removed from the central management of hypertension because of various mortality studies, and also only in patients with special indications. So patients who have hypertension and heart failure, obviously you're going to use your beta blocker. Patients who have ischemic heart disease, if they have hyperthyroidism, for instance, or some other indication for the beta blocker, obviously the beta blocker is going to be part of the treatment. But for essential hypertension in primary care, we're not going to start someone on Atenolol, definitely not Atenolol, but not even Bisoprol for hypertension. Okay, so there are advantages of combination therapy, and I'm glad to see that you do have several combinations. First of all, what percentage of patients will be controlled on the monotherapy at step 1 of hypertension treatment? Less than 20%. So we're really only fooling ourselves when we start with this amlodipine 5 milligram and say, oh, try this and come back in 3 months. I mean, 80% of those people coming back in 3 months still are not going to reach target. We just don't want to start combination therapy because we think, let's start with 1 drug and then go to 2 drugs. The WHO has changed this in our guidelines, and the recommendation is actually to start combination drug therapy. First of all, there's greater efficacy. I'm glad the pharmacists are on here, because you're really the only ones that understand this in-depth pharmacology. There is additive and synergistic effects, so the drugs complement each other. It allows lower doses of the individual drugs. So rather than using amlodipine 10 milligrams, you can use amlodipine 5 milligrams and maybe telmisartan 40 milligrams or 80, or some other half dose of the complementary drug. There's a simplified drug regimen, so there's better adherence. Patients don't even know sometimes what are the 2 component drugs in this tablet. They just need to know they have to take half a tablet. And then I'm having a conversation with them. If your blood pressure still isn't on target, then we're going to take the whole tablet. And then if it still isn't on target, then we're going to have to add another drug, which is usually the diuretic. In the case of Antigua, I'm very pleased to say they may not even have to come back for the diuretic, because your diuretic is already included in your combination. So it reduces clinical inertia, which we've already said is a big factor. And I'm going to skip the mitigation factors, but these slides are all going to be available to you, I think, with Dr. Cordner's permission at the end of the presentation. The ideal fixed dose combination has several properties. So first of all, it has high efficacy. I mean, it makes no sense if it's a fixed dose combination if it doesn't really lower your blood pressure. The drugs should be synergistic. You shouldn't have a drug like an ACE and an ARB, because that combination should never be prescribed, and that should be a red label warning by pharmacists. Sometimes some house officers might accidentally do that, and they might write it on the drug card, or if you're using your EMR, it will not allow you to enter the 2 classes in your electronic prescription because it's contraindicated. So the steps in selecting an ideal fixed dose combination: first, select the preferred acceptable pharmacologic drug classes, maybe an ACE inhibitor or an ARB, not and, plus a calcium channel blocker, or maybe an ARB/ACE, and a thiazide-like diuretic. Then select the preferred or acceptable pharmacologic agents in each drug class. So then you choose, well, what's my thiazide-like that I'm going to choose? Maybe chlorthalidone, or maybe, as you have done in your formulary, indapamide in your combination, I think, with perindopril and amlodipine. And then select which preferred and acceptable combinations are available and affordable. I said to some colleagues in Trinidad who created this really nice algorithm. I mean, it really was first world. And then I said, okay, so how many of you have these drugs in Trinidad? They said, oh, we don't have any of these drugs. Well, what's the sense of having an algorithm and you don't have the drugs in the country? So your algorithm has to have the available drugs that you have in your country. And don't aim to start at the best algorithm, although Antigua, you've kind of started at your best case scenario. But even if you did have a thiazide-like diuretic, start with a thiazide diuretic. Or if you did have expensive ARBs, use the ACE inhibitors. Just don't say that I don't have it, so I'm just going to not use an algorithm. All right, and I think I have your example in here. So here's an example of how this might be structured. An ARB plus a calcium channel blocker, or an ACE plus a calcium channel blocker. Note to the residents, because this is a frequent question on your US MLE exams, the calcium channel blockers actually do have natriuretic effects. So they do cause a natriuresis. So you aren't using a diuretic, but you're still getting rid of sodium. So no, they're not diuretics, but they do cause natriuresis. Okay, and then your next step, you've got your ARB plus your thiazide-like diuretic. And the thiazides, as I said, are no longer used there. So those are some of the possible combinations you might use. This is an old protocol, so I'm not really going to drill down on it because I have provided you with your more modern, sophisticated protocol later in the presentation. But here are some options. You've chosen perindopril. I think as your ARB, you've also chosen telmisartan. Telmisartan is a good ARB. We made a mistake in Barbados. And this is embarrassing for me because I do chair formulary committee, but we started with valsartan. The valsartan data was impressive. However, in terms of its duration of action, telmisartan has a longer duration of action. Chlorthalidone is also possibly your thiazide-like diuretic of choice. I noticed that you don't have that in your combination. We only recently have that in our combination, but it's locally produced and manufactured here. It has some advantages. One, it does have less of an effect on hypokalemia. It also is one of the longest acting diuretics. I mean, you don't want to tell patients this, but even if they forgot to take their chlorthalidone, its half-life is almost 72 hours. It has a long duration. But more importantly, the thiazide diuretics serve another important function. They cause smooth muscle relaxation. And so they're not just natriuretic, but they actually cause your blood vessels to relax as well. All right, so the conclusion slide here, use a standardized algorithm, determine blood pressures validated with validated equipment. I don't think any of you are still using the old mercury pump up equipment and listening for Korotkov songs. Some second-year medical students told me last week they don't even know what Korotkov songs are, which is not good, but just to show you they've gotten so accustomed to validated devices. I should say that the WHO has a separate blood pressure device committee. I mean, that's really all they do, study blood pressure devices. It's kind of boring, but they came up with a validated set of devices, which you can go online and see what they are. I can't really recommend brands, but I can tell you what brand I use. I tend to use the Omron 7 or 10 series because it has the IntelliSense cuff. It's slightly more expensive, but it does last long. It's more durable. For your patients, your rheumatologic patients who might have problems getting the dexterity with the cuff on, this is a semi-rigid cuff. So it kind of just slips on and you fold over and it's in place. It has IntelliSense technology, so it can also detect arrhythmias and ignore certain blood pressures. So it's kind of your Rolls Royce right now for blood pressure measurement, and it costs just about between $75 and $100 US. All right, so now I'm going to move into the WHO new guidelines that were released 2 weeks ago in my final 10 minutes, Dr. Cordner. 10? Okay, all right, I'll go quickly. Okay, so and I'm glad that I only got the permission this week to share this with you, but
No,
you are
you
actually
have as much time as you need. We're enjoying your talk. Thank you.
Thank you, Dr. Coroner. So this presentation, Antigua and Barbuda, you are the first country outside of the main launch to have this presentation. And I'm glad this is recorded, and I know the Formulary Committee here is going to kill me, but I haven't done this presentation in any other country as yet. So the launch was about 2 weeks ago by Dr. Tedros. Although he's focused a lot of his time to a lot of political division in terms of vaccines recently, he also has spent a lot of time with us on the hypertension guideline, making sure that we've gotten things correct, and also making sure the guideline can stand up to the science, but most importantly, making sure it's extremely user-friendly, and as he put it, COVID resistant. In other words, we don't want a complex guideline that healthcare professionals can't manage patients remotely, because who knows, we may have to be managing patients remotely moving forward. And so there are a number of non-pharmacological approaches involved in, and we mentioned a lot of those before. But we focused on the pharmacologic management. So we looked at the blood pressure for starting treatment, whether labs or lab tests or cardiovascular risk assessment are needed. And I'm really curious of what your thoughts are on this. I have to say, this is the area of the guideline that I focused on and I chaired. And I hope that we have made it simple enough so that the practitioner in the rural part of Antigua can feel comfortable starting a class of drugs without having to worry about getting electrolytes or checking the urinary protein, so that you can just start treatment. Remember, the barrier is starting treatment. Too many people who are diagnosed with hypertension, we're delaying treatment, waiting on a lab. I need to know the sodium. Why you need to know the sodium? Because I don't want to start a diuretic and then they go hyponatremic. I mean, how many patients have you started your diuretics on that have gone hyponatremic, or that you've pushed it? This is the average patient out there with hypertension that you've pushed into acute renal failure because of the diuretics. So those are kind of barriers that we hope that we have removed. But we also looked at, of course, follow-up intervals, and most importantly, the use of non-physician healthcare workers, because pharmacists have an important role. Or pharmacists, for instance, they have a blood pressure machine at the counter. And guess what? When patients are waiting there, when they're dispensing meds, they tell them, let me just see you put your blood pressure cuff on just to make sure you're doing it correctly. Patients, of course, it's kind of unusual. The pharmacist asks me to do a blood pressure, but they do recognize, for instance, that we're trying to drive home the importance of taking accurate home readings. So the pharmacist is going to say, okay, so that was on almost perfect, but remember that the tubing is meant to come down in the middle of the arm, and you should actually be seated when you're doing this reading. And I know you're seated now, but don't cross your ankles. So just reinforcing what we've already said in the consultation. So this is just some notes on the WHO Steering Committee. The guidelines took just about 2 years. Several face-to-face meetings and even more Zoom meetings, several arguments. Academics argue too much over minutia, but we also had the contribution of nephrologists, cardiologists, nurses, researchers. Patient advocates were also part of that group in the latter part of the guideline. So for instance, patients might say at the end of these very nicely crafted guidelines, this is not going to work because I can't be doing blood pressures for 2 weeks before the next visit. You know, I have a life outside of blood pressure. You need to say something that's more reasonable and make sure that be very specific. Don't tell me take some readings. Tell me take 2 readings a day for the 7 days before my appointment. I can live with that. You can tell me do readings otherwise, but I'm going to be really meticulous those 7 days before my appointment. And this is just the journey along the way. And I said these guidelines, these slides are going to be available to you. And here's how we analyze the data and to come to the final recommendation of thousands and thousands of studies later. The evidence is weighted either strong so that the benefit to healthy outcomes is definitely there, and the undesirable effects may be there, but it's very much outweighed by the healthy outcome benefits. And any recommendation that is conditional or weak or expert consensus then the shade color used in the recommendation changes from dark red to pink. So basically, the lighter the color, the less evidence we have for that recommendation. Okay, so here's the first question. At what blood pressure should we initiate pharmacologic treatment? So WHO recommends that pharmacologic treatment is started for blood pressures greater than 140 systolic and diastolic greater than 90. It's a strong recommendation because there's lots of evidence to show this. We also recommend that for patients with existing cardiovascular disease and systolic blood pressures between 130 and 139, that you should also start pharmacologic treatment for the management of their blood pressure. Where the evidence is not as strong is for patients without cardiovascular disease, but who have high risk factors. How many of you have downloaded the WHO risk calculator? I should tell you that Antigua is a country featured there, so you get to choose your country, and it gives you a country-specific risk. So it's kind of cool. And if you have a high cardiovascular risk, type 2 diabetes, chronic kidney disease, or our systolic blood pressure between 130 to 139, it's conditional, and it really would depend on what I like to call the softer risk factors. You know, does this patient have rheumatoid arthritis? So they have chronic inflammation, or do they have inflammatory bowel disease? And how do you know that they might have a chronic pain condition? Because they're the same patients taking the Voltaren that Dr. Meade mentioned, which is elevating their blood pressure. So be very suspicious of patients with the non-traditional risk factors. You should initiate treatment no later than 4 weeks after diagnosis. Now, this is so important, and this was a big debate. Oh, let's bring them back in 3 months. No, you should try to initiate treatment in no more than 4 weeks after you've diagnosed hypertension. Get these patients on treatment. And if the blood pressure is more than 160 systolic or diastolic more than 100, or there's accompanying evidence of end organ damage, initiate treatment as soon as possible. Don't kind of say, go home, eat some more fruits and vegetables, take less salt, and come back and see me in 3 months. Because I know junior doctors love to put that 3-month stamp on the notes. You should start treatment and set targets immediately, because this is a person that is really at increased risk of therapeutic inertia from us. The second recommendation. Now, when starting pharmacologic treatment for hypertension, WHO also suggests obtaining blood tests for screening for comorbidities and secondary hypertension, but only when testing does not delay or impede starting treatment. Do not wait on the cholesterol. Do not wait on the HbA1c. Don't wait to see what the sodium is. If this person has 160 on 100, start treatment, okay? And this is a conditional recommendation because actually the evidence for this is mainly expert-driven and not by randomized controlled trials. But certainly, the way the guidelines are constructed, we've used the safest drugs at the lowest level. So at step 1, you're using kind of a metabolically neutral drug, amlodipine, and you are complementing it with an ACE ARB. So there's several advantages to that. You decrease the pedal edema from the amlodipine. You also increase the efficacy of the vasodilation that you're getting. In terms of the dosing, the drug is dosed at night. So you're trying to decrease the pedal edema again by dosing the combination drug at night. How many of you are dosing your blood pressure medications at night? It's kind of new in the guidelines as well. I know WHO does mention it, but even the diuretics we dose at night because the renal perfusion increases when you're standing, when you're lying supine. So it's not going to keep you up all night peeing. Although patients do think that this is what's going to happen, it doesn't. Okay, so we suggest testing such as the electrolytes, lipid, HbA1c or fasting glucose, a urine dipstick, and an ECG. I didn't necessarily agree with the ECG, but I was outnumbered. And the reason for it is I think we really want to say echo here, and Dr. Meade might be happy because hypertension is now a stage of heart failure. And we certainly would like, in the ideal world, to know the cardiac function of all patients with elevated blood pressure, but it's not possible. So if you have LVH on the ECG, and this is what I said to the guideline committee, what are you going to do? Treat the blood pressure. If you don't have LVH on the ECG, what are you going to do? Treat the blood pressure. So it's not really going to influence treating the blood pressure. But in low resource areas or non-clinical settings, when testing may not be possible because of the additional cost and the lack of laboratory or ECG, treatment should not be delayed. You should start treatment as soon as feasible. The third recommendation, WHO suggests cardiovascular risk assessment at or after initiating pharmacologic treatment. This is highly controversial. And I have to say that initially there was a big split between the guideline committee on this. We decided, however, to include it because the developing evidence seems to suggest that we should be risk stratifying more. But I do want to say here, although all risk factors are part of risk stratification, all risk factors are not equal. Hypertension does stand alone. So if you have an elevated blood pressure of like 150 on 100 average, do not say, well, you know what? Your risk calculation is still low, so I'm not going to treat your blood pressure. You need to treat that blood pressure, okay? The risk models, the risk calculator, sorry, that's used by WHO is designed so that you can calculate the patient's risk based on your pooled cohort for your region, for your country, because Antigua is there, without the cholesterol. So even if you don't have labs, that's not an excuse. You have the age, you have the blood pressure, you have the other factors that are needed to calculate that patient's risk. And of course, record that risk in the note. Don't just kind of, and show it to your patient. They like to see the color coded when it's green, when it's amber, and of course, they don't like to see it when it's red. And you try to convince them that, you know, you can't change your gender, your race, or unless you're Michael Jackson, but you can't change any of those other things, but you certainly can, you can really change your blood pressure, so you can get on top of that and get your risk, your total risk stratification down. And here's what it looks like on your iPhone or Android, and you just access it. I think I have something here showing Antigua. Yep, here you are in the drop-down menu. Antigua is there. Plug in your country and you can calculate it. By the way, it's just not doctors that are doing this. So pharmacists are doing this as well. They have these conversations. Dr. Connell has showed us that it does exist, and they do calculations all the time for patients, and the whole list of countries is there for you. The next question, recommendation on drug classes to be used as first-line agents. So again, we've stuck to the first three that we described, thiazide or thiazide-like agents, although we haven't listed any of the thiazides and they have been removed from the actual algorithms. ACE inhibitors are still there. I think the guideline committee does expect that in the next few years, the ACE inhibitors might largely be replaced with the ARBs because they're safer and the side effect profile is there. I want to emphasize here, it's long-acting dihydropyridine calcium channel blockers. You know, in our setting, although this isn't stated in the guideline, this is mainly just one drug, amlodipine. I mean, think about it. Even if you have the slow release nifedipine, which is Adalat, Oros, I think goes to 24 hours. And nifedipine SR, although it claims to be 24-hour acting, is really only between 12 to 16 hours. Why we make a big deal about this is because you do get blood pressure starting to rise in, if you're taking the morning dose, starting to rise from as 7 p.m. and 8 p.m. at night. And that's dangerous. And even if patients are taking the medication later, it's even more dangerous because then you get the rise occurring in the what we call the early morning surge in blood pressure, which is extremely dangerous because that's when most strokes and heart attacks occur, between 4 to 6 a.m. when your sympathetic activity starts to rev up as you're starting to enter the awakened state. So you definitely don't want to use a short-acting calcium channel blocker because you're putting your patients at an increased risk. Even in pregnancy, and I've convinced our obstetricians, gynecologists, colleagues on this now. I know they love me because they don't have to worry about making all these excuses to get short-acting nifedipine, which is very difficult to get from our pharmacy because our pharmacists are not going to dispense it. They're going to want to know, what are you using it for? And if you say hypertension, they're not going to dispense it. So you have to really come with another indication. And I know that this is not always the case because every time I hear it's for tocolysis or it's for headaches or some other dubious indication. So long-acting calcium channel blocker. I also want to say here that for those people who are extremely sensitive to the pedal edema, even in the combination, your option is felodipine. It has a lot less pedal edema than amlodipine. It's once daily as well, and it's an equivalent dose, so milligram per milligram. I probably have about 5% of my resistant hypertension patients on felodipine, but I have to write an SAD for it because it's not going to be dispensed like that. The fifth recommendation, which is a strong recommendation for combination drug therapy. And although several combinations were used before, we've kind of been consistent for not using the calcium channel blocker diuretic combination because data from the Creole study actually showed that of all the combinations, this one was the least effective at lowering blood pressure. It actually lead to some adverse metabolic outcomes. It's no surprise there because remember, amlodipine also causes metabolic shifts in sodium, and of course your diuretic does the same thing. So the preferred combination is one of your RAS drugs, which is an ACE-ARB, or with a calcium channel blocker. The sixth one, what is the target blood pressure? A strong recommendation that you target your blood pressure less than 140 or 90 in all patients with hypertension without comorbidities. Now, I almost don't like to tell patients this because they get that 139 at home and they think, eureka, I'm good to go because it's less than 140. But you really want the blood pressure as low as possible. Remember, the lower your blood pressure, the lower your cardiovascular risk. Well, up until a point where the higher your blood pressure, the lower your blood pressure, the higher your risk as you get your J-shaped curve occurring. And especially nephrologists on the call are going to be very particular about the blood pressure. So if you do have cardiovascular disease with hypertension, then your aim should be less than 130. Now, the caveat for the 140, remember, these are office readings equivalents. So your home equivalent is still going to be your 130 or 85. So don't use your home reading as 140 target. WHO also suggests a target of less than 130 in high-risk groups with hypertension, such as on your risk calculation, patients living with type 2 diabetes, and also those with CKD. Fourth question, frequency. It is recommended that follow-up after initiation of antihypertensive treatment should occur until patients reach target. They used to be, and actually there still is in the NHANES data, if you haven't been seen for more than 6 months, you're coded automatically as uncontrolled. Regardless of what your blood pressure is, you have to be seen at least 6 monthly to be coded as control. But we do suggest that you see patients between 3 to 6 months whose blood pressure is under control so that you can make changes. Or again, remember, you're kind of the coach as well, trying to get them to take their blood pressure medication. And I know that you've forgotten to take your medication a few times, or I know that you're struggling with reducing the sodium. So the visit is not only just to kind of just rubber stamp the prescription. And the fifth recommendation is, of course, this eighth recommendation is non-healthcare professionals. WHO suggests that pharmacologic treatment of hypertension, now this is, I know, controversial for our part of the world, but can be provided by non-physician professionals such as pharmacists and nurses, as long as the following conditions are met. There is proper training, there is prescribing authority, and there are specific management protocols, and there's some physician oversight. So I guess this would be in countries that have pharmacist prescribers, as well as physician assistants and non-physician prescribers as well, in their nurse practitioners as well, who would be using this. And in Latin America, this is used quite a lot because there aren't enough doctors. So for those countries who are still only able to use a single pill combination, I just put this up here, but I mean, you're not one of them. For the combination treatment, again, we said treat blood pressures more than 140 or 90. Start with 2 drugs from these classes that are shown here. Get your target blood pressure down, and if it's not, get your blood pressure to target, sorry, and if you haven't met the target, again, in 3 to 6 months, titrate up. Try to reduce the inertia. At your next step, and I say this to residents, try to convince yourself why you should not be titrating. I'm not saying, you know, if this patient is perfectly controlled, say, you know, I've got to titrate them up, but really try to convince yourself why not to titrate rather than to convince yourself to titrate. Because physician inertia is a serious thing in primary care. And you can't see this protocol here because it's too small, but that's okay because I have your drugs here. If I can, okay. So these are the drugs you have available on your formulary. And immediately I zoomed in to the last three here: perindopril, indapamide, amlodipine. I wish I could just send this to the entire guideline committee right now because we would be so excited. This is an ideal combination. You've got your ACE, your thiazide diuretic. I noticed that you chose indapamide over chlorthalidone. And amlodipine is there at its various strengths. Now, the other thing I like about this, this guideline and this combination is that you do have some nuance here with indapamide. You have a 1.25 combination here, which is great because some people are very sensitive to thiazide-like diuretic, and so the 1.25 might be sufficient. I really like the fact that you have eplerenone here, and I'm not going to claim any credit for it. But at step 4 of the guideline, remember we said step 1 is your ASR plus the CCB at half dose. Step 2, both those drugs at their maximum dose. Step 3 would be to add the thiazide-like diuretic. And step 4, well, you have some options because there really isn't as much evidence once you reach step 3 anyway. You can either consider titrating up the thiazide-like diuretic, which most people don't usually do. I mean, your antihypertensive effect is going to be capped out at this dose of the indapamide in any case. There's probably not even much benefit going from 1.25 to 2.25. And certainly for chlorthalidone, going above 25 milligrams for hypertension is really, you're moving more into the diuretic range rather than the antihypertensive range. Eplerenone is a great drug. And why is it a great drug? Because not only is it a mineralocorticoid antagonist or MRA that makes Dr. Meade excited because it helps in heart failure, but it also helps with arterial stiffness and salt-sensitive hypertension. And who is the salt-sensitive population of the world? That's us. So here's another tip. If you have patients who have resistant hypertension and a low or normal potassium in your clinic, they're salt-sensitive until proven otherwise. Potassiums of Black people who are resistant hypertensive should not be normal. And they definitely should not be low. So be very suspicious of that. And if you have the facility available to go and get the expensive renal aldosterone level, you can do that. But if not, you might consider that this person is salt sensitive and start eplerenone at 25 milligrams. Of course, I'm glad that Antigua can afford eplerenone. And I know that the GG is on the call, but spironolactone is also an option. And you probably have this in your extended formulary. Some men are extremely sensitive to spironolactone with gynecomastia and erectile dysfunction. This is my reminder to remind all of you to bring up the conversation of erectile dysfunction with all men in the clinic. I have to be specific here because my house officer 2 weeks ago brought it up with a woman. So bring up erectile dysfunction with all men in your clinic and say to them, is this a problem? Because if it is, switch spironolactone to eplerenone. Again, it's a milligram per milligram dose, so you don't have to worry about what am I switching them to. And start at 25 milligram. And you can actually get away with 12.5, by the way, because some of us are very salt sensitive. So even the eplerenone 12.5 is sufficient. And guess what? You have your diagnosis because once you have started eplerenone and they reach target, you don't even have to do the renal aldosterone level. You kind of know this person is salt sensitive until proven otherwise. And you might consider other screening now. You know, do I need to be thinking of another cause for hyperaldosteronism, like a Conn syndrome? So again, I always say to residents, don't just add potassium to people's diet. Why are they taking excess potassium? Why are they hypokalemic? It's not just the diuretic. That should not happen with the normal kidney, especially if you have resistant hypertension at step 4 treatment. So be very suspicious of that. And finally, the next steps in these guidelines, of course, they've been published, they've been rolled out. Implementations such as the one that I've done here. We hope to have one-on-one sessions with physicians, hopefully remotely, but also hopefully face-to-face as well. There's in-country training. I would like to encourage everyone in Antigua, of course, to try to adopt the HEARTS protocol, even though you're not a HEARTS country as yet, but there are so far 26 HEART countries around the world. And so HEARTS is coming to you soon, I'm sure. It's signed at the governmental level from WHO, and you don't have to implement all of the packages, but certainly the HEARTS package is one that you can consider. And on that note, I am going to end the Tour de France here and open the floor to questions. Thank you very much.
Thank you so much, Dr. Kenneth Connell. I was actually saving the phrase Tour de force for you to say thank you very much for taking us so eloquently through so many steps in the management of hypertension, and for actually consolidating it with the general lifestyle public health recommendations before getting into the nitty-gritty of our drugs. Our drugs are important, but as you know, everything else is as well. I want to take some credit for having chosen you to speak this morning. I think it was a very an excellent choice, and maybe we will cajole you into giving us another presentation in the very near future.
And in person.
Well, there are direct flights from Barbados. We'll be happy to have you. I think it'll be well worth the airfare. First, we're going to start with the questions that have been posted in the chat.
Sure. I'm going to try to pull them up.
I should have written down the question I had, but I forgot it by now. Oh my. Okay, so the first question is from our very senior pharmacist, Mr. Atil. Can you please amplify the significance of persons recording their BP post-doctor visit in relation to the long-term benefits to patient control and cost to the procurement agency? Would you recommend these patients get the blood pressure unit from the agency medical benefit scheme, those who cannot afford to purchase?
So, you know, this question really does sound like it comes from the chief pharmacist, because the chief pharmacist here, Miriam Hines, asked the exactly the same question. 60% of the Barbados drug budget was being spent on antihypertensives, and our control rate was less than 30%. And obviously we were wasting money. And part of that is there was a lot of over-treatment of patients with hypertension. I mean, there was a lot of under-treatment as well. So people were on the medicine ward, for instance, with a blood pressure of 160, they would get slugged with like 3 antihypertensive drugs because they're in a hospital. They'll go home and get all of their hypoperfusion, and unfortunately, some of them might have a stroke as a result of that, or a fall. And so certain things had to be implemented. For instance, you cannot be seen in the hypertension clinic now unless you have an out-of-office monitor. And we get donations from various banks. CIBC has been great at this. Various foundations like the Arnott Cato Foundation. As I said, we've stopped the whole glucose monitoring strips machines because, again, in diabetes, the marker for mortality is blood pressure control. So why not give them a blood pressure device? And patients, you have to drill home this thing that, this is an important device. It's not only going to save us money in terms of procurement, but it's also going to decrease your mortality and morbidity. And I frame it just like this. Here's why I need to have your home readings, because it is very likely based on your office readings that I could be over-treating you or I could be under-treating you. I don't know, I'm guessing. Patients don't like to hear us say things like that, so that's why they bring their blood pressure reading. So that's an excellent question.
Especially Dr. Connell, a lot of patients will say that they did not bother to take their antihypertensive medications on the morning of the clinic because they were coming to the clinic and therefore leaving their homes without breakfast or something.
Of course.
And added frustration.
I have to say we get around that because ours are now taking theirs at night.
Oh yes, well that's great. And to remind everyone, the talk was really focused on the outpatient management of hypertension, and that inpatient titration of blood pressure is a completely different topic that can be addressed.
Oh yeah, definitely.
So Dr. Alafia Stevens Gordon, who is the president of our medical association, the Medical Association of Antigua and Barbuda, asks a lot of patients are on multiple antihypertensive medication without maximum doses of some or all. Is this practice correct? Not maximizing the dose of hypertension medications before starting a new medication?
I think that's an excellent question, but I think it also depends on what combination they're on. So for instance, for the combination drugs, like I mentioned, the amlodipine calcium channel blocker, we actually want them on a combination before they've maxed out on either the calcium channel blocker or the ACE-ARB. So that is acceptable. But I take your point completely. And I know that I've seen this where patients are on like 6 or 7 different classes. Usually it's a junior doctor who is too confident in prescribing a higher dose. So they just kind of, it's almost like a pillow is what we call it in Barbados. You kind of throw a little bit in and hope for the best, but that actually increases. Remember, you're increasing your adverse effects from polypharmacy if you're moving from 5 or more drugs. So the drugs, the only justification is that these drugs must be synergistic in their mechanism of action, and therefore their efficacy is improved in combining them. And that's when you would combine drugs rather than titrate up. But remember, from step 2, it's easy. Step 1, half dose of the calcium channel blocker, half dose of the ARB. Step 2, double the dose to the maximum dose. And step 3 is when you're adding the diuretic. So, you know, you have to really convince yourself, well, why is this person on methyl-dopa? Even in pregnancy, we don't use methyl-dopa anymore. Or why are they on minoxidil and bisoprolol? You know, so the pharmacist is not going to dispense it because they're also following the same algorithm. So it's going to be pretty hard.
Thank you, Dr. Kenneth Connell. Okay, Suzanne Samuel Lake asks, do these methods produce good results in your patients, and what percentage? Also, is cholesterol and diabetes significant in them? In terms of physical exercise on a patient who has other medical conditions such as arthritis in the lower back, hips, and knees, what would you recommend? I mean, bad progressive arthritis.
Okay, I think I got the question. So does it produce good results? So the national average for blood pressure control in our primary care setting is 34%. In clinics that have adopted the HEARTS protocol, that's now up to 58%. When you think about it, you might think, well, what's 58%? You know, what about the other 42%? But when you think about the most stringent healthcare system possibly in the world, Kaiser Permanente, where everything is literally regimented because it's a veteran system. I mean, they got their control rates in the 70s after like 2 or 3 or actually 4 years implementing the standardized treatment protocol. So it takes some time. In my clinic, and I have to say, so it's a resistant hypertension clinic, these people have reasons to be motivated. Our control rate is 84%. But again, these are people that have resistant hypertension. So they're really dedicated to getting control. And for your arthritic patient, I mean, one of the first screening questions I ask patients are you taking any tablets for pain? And if so, what are the over-the-counter medications you're taking? And I immediately stop NSAIDs because for patients more than 60, the number 1 cause for pseudo-resistant hypertension is NSAID use. It's not really resistant at all. They're just taking NSAIDs. And I switched them as I'm pleased that Dr. Meade has stated acetaminophen or acetaminophen plus codeine. Remember, paracetamol has to be taken on an empty stomach, and the adult dose is 1.5 grams and not 1 gram. So for severe pain, you really do need to use the 1.5 grams.
Thank you, Doctor. Kazan Christian asks, what are your thoughts on prescribing once a day extended release hypertensive drugs in divided doses? For example, nifedipine extended release 60 milligrams twice a day versus nifedipine 120 milligrams once a day. Similarly, for hypertensive drugs with relatively long half-lives being prescribed in divided doses. So amlodipine twice a day versus once a day.
Yeah, I never do it. I never do it. And I have to say the last... I never prescribe them in split doses. So it's always going to be once a day. And even I like the example of nifedipine because the one class of patients that I would have had to use nifedipine in because it wasn't as supporting the guideline was in pregnancy and breastfeeding. But now amlodipine is used, and I use amlodipine once daily. You definitely should not split the amlodipine pill because of some pharmacokinetic properties of amlodipine. So you definitely should prescribe it as its once daily pill. In fact, there are some drug companies, I'm not sure whether this is marketing or whether this is genuine pharmacognosy, but they advise don't break the tablet either because it is a slow release tablet, the formulation. Certainly if you're using Adalat Oros, I know I'm speaking to pharmacists, so I'm going to be very careful. There is this special membrane inside the capsule that actually expands in the as it's in your gut, and it kind of squirts the nifedipine through this very small. So patients can't chew the capsule or break it in half because it defeats the purpose. So the indirect answer to your question is do not prescribe it twice daily. Choose a once daily time, preferably in the evening, and that will last for the 24 hours if it's amlodipine. If you have to use the SR, I mean, if you don't have amlodipine, then yes, you have to do it twice daily. So that's the other thing. If you have the SR, you can't use once daily because you're not going to get 24-hour coverage. Yeah, but that's not ideal. And there was another point about lifestyle. What was that?
Not in this question.
Not in this question. Okay.
There was the half-lives.
Right, half-lives. Now, half-lives are things that are used, interestingly, by drug companies to fool prescribers into thinking that their drug is, but so the half-life of a drug is obviously affected by the design of the capsule as well. So drugs with shorter half-lives, you can prolong the duration of action simply by changing the design of the capsule. I mean, Adalat Oros has done that, right? Nifedipine's half-life is not 24 hours, or it's not even 12 hours, but you've prolonged the half-life by the way the drug is released from the capsule. So I don't think half-lives are important in real practice as we try to make them. It really depends on the duration of action of that product. Most of the antihypertensives, the calcium channel blockers certainly have a duration of action that is 24 hours regardless of the half-life, except nifedipine SR and of course, short-acting nifedipine.
Thank you. Susan Samuel Lake is asking about arthritis again, but I think we sort of covered that question and can come back to it time permitting. Kazan Kristen is asking also any thoughts on centrally acting antihypertensives in current times?
Okay, so this is definitely at the point where you want to be referring to your specialist. I do use centrally acting drugs. I have to admit, I didn't go through my step 6, 7, and possibly 8 in the algorithm because I don't want you to get confused into using those drugs. But because there's limited evidence, it's really then up to the expert opinion once you move past step 3. So for instance, if it's a male, I might use minoxidil because most of the time men aren't really worried about shaving the beard and the hirsutism. But I have to realize then that if I'm going to use minoxidil, I probably am not going to get away with a thiazide-like diuretic because the fluid retention is going to be too much, and I may have to switch to a loop diuretic. And I will have to add a beta blocker because minoxidil is going to cause reflex tachycardia. So those are the nuances that I don't think that you want to deal with in primary care. And as soon as you're moving past step 4, and I think that step 4 can be easily managed in primary care with, eplerenone, for instance, you should be getting specialist care and looking for other causes for resistance.
Thank you. So an anonymous attendee would like to present a question to MBS management on the formulary committee. How do you respond to the idea of giving diabetics a blood pressure monitor versus a glucometer device? Mr. Bovell. Okay, on behalf of the formulary committee, I would like to defer the response to that question until the committee has a chance to interrogate the issue properly. So Mr. Bridgewater, our head pharmacist for the hospital, also a member of this formulary committee, is asking, should the practice of selling antihypertensive drugs to patients not seeing their physicians under 3 months be curtailed, especially if these patients don't own a blood pressure monitor, cannot provide a blood pressure reading within the last 2 weeks? And should the patients be given repeat prescriptions for hypertension agents for more than 3 months?
Yeah, so before my answer to this would have been definitely not. And then guess what? Then came COVID and it was impossible for patients to be seen. So I think there has to be a middle ground here. And what I do like about many of the pharmacists here, we have this distribution conglomerate here, Massey Stores, Massey Pharmacy. You can kind of get your blood pressure medication if your prescription is out. You have to show your home readings. You just can't go and say, just give me my blood pressure. So they're going to ask for your home readings, and some of them will actually call the physician and say, I'm repeating the extended medication, just letting you know, kind of thing. They're also more likely to extend the medication if you are in the HARTS protocol because they know what is being followed and they kind of know, what is going to happen. So the answer to your question is it could potentially be dangerous, because I have also seen cases, for instance, where patients are on beta blockers for other reasons. I mean, they have hypertension, but one of my patients, she has hyperthyroidism as well. And she wasn't adequately beta blocked. And she just continued on her, of all the drugs, propranolol. So I normally wouldn't keep patients prolonged on propranolol. Once they become euthyroid, I would switch them to a non-thyroxine converting, beta blocker like Bisoprol. But she continued on propranolol for 9 months because she just did not return to the visit. So there is danger, but I think pharmacists need to make that call.
Well, you also mentioned in your talk that the pharmacist is another opportunity for the blood pressure monitoring on that visit. So it would be an opportunity for them to check. So Nurse Susan Samuel Lake would like to know from Dr. Connell, for the arthritis patient referred to earlier, what physical exercise would you recommend, Dr. Connell?
Right, okay, so we do have quite a few arthritic patients in our cardiac rehab gym, and they use, it's the ergometer. They do a lot of upper limb movements if the arthritis is mainly in the lower limb. We also recommend a lot of what we call joint support exercises, which is usually in the swimming pool, where they get a lot more support. And of course, pain control. So the physiatrist is definitely involved in these patients. We can't have patients exercising in pain. So they have to be on top of their pain. And if the rheumatologist is involved, for instance, discussion about why the patient is not on a DMARD, for instance, and just on pain medication. So those kind of questions come up. In other words, is the rheumatic disease adequately being managed? Or is this just some patient who is coming with debilitating rheumatoid arthritis who really should be seeing a rheumatologist and being treated? But in response to your question, we would definitely tell them to stop the NSAIDs and to use a safer analgesic. And the exercises used generally would support the joint. So they're not going to go on the treadmill, for instance. They do a lot of, by the way, now in COVID, we have a lot of remote cardiac rehab. Dr. Meade would be happy to know this, where they can log on to these programs and do these with the cardiac rehab nurses at home, send in their blood pressures and pulse, those kind of things.
Dr. Ian, thank you very much, Dr. Connell. Dr. Ian Thomas remarked in the chat, great talk. We were not finding too many combinations with chlorthalidone. Which ones do you have available in Barbados? But before you answer that, Antigua now has in its possession chlorthalidone, I think sourced out of Barbados. So we've already commenced that. So
right. Okay,
which
so
combinations are you using?
So the one that we use, the only one that we use, because it's locally available, I know it's difficult, although because the WHO have now changed their guidelines, there are going to be a lot of chlorthalidone combinations coming out, I'm sure. But there is a locally available one that's combined with chlorthalidone, amlodipine, and telmisartan. And that's by Armstrong. Is it Armstrong or Collins? But it's produced locally. I have to admit, although there was a lot of resistance from our Formulary committee, because of course they want to see the evidence that it works. Patients actually seem to prefer it because, well, for one, the blood pressure control is better, but they also don't seem to experience a metallic taste that some people get with the chlorthalidone. So that's the combination that's used. Of course, other combinations are possible. Some people prefer just the chlorthalidone and the ACE-ARB, but you definitely should not combine the chlorthalidone with the calcium channel blocker, because you want to make sure the prescriber definitely has an ACE-ARB in there.
Thank you. And I'd like to take chairman's privilege and ask how, if in any way at all, has your prescribing for hypertension changed with regards to COVID infection?
Yeah, it has changed significantly. For one, it has become remote. So there are a percentage of patients who I have had to say to them, okay, so based on your readings for the last 2 weeks or so, you're not on target. So we need to move to step 2. So take the whole tablet and not half of it. Or I'm going to send you a prescription. Our pharmacy actually started doing this home delivery at a fee. I think it was like $5 for your water pill. But again, they're anticipated because they were at step 2 that the next step would be the water pill, the chlorthalidone. Certainly, I have been a lot more aggressive in controlling blood pressure because I know it's so linked to outcome. And I know that we try to minimize blood pressure control and it's linked to heart failure. But remember, in the SPRINT trial, the whole reason why SPRINT possibly incorrectly recommended these much lower targets, it was really driven by the heart failure patients. And so we really do need to make sure that we have blood pressure under control. It's what's causing all of the hospital presentations in heart failure. And then of course, later on, I expect we will then see the tsunami of strokes coming in a few months.
Yeah, strokes for so many reasons, but I remember at the beginning of COVID, a lot of patients were taking themselves off of their ACE inhibitors and ARBs for fear. And then we had to reinforce that no, having controlled blood pressure was far more important than which agent was being used to control you. And of course, COVID in itself is going to increase your risk of stroke. So it's everything is being compounded now, but it's, I think, a reminder for us all to remain on top of our health and to be as stringent as possible with meeting our guidelines. If there are any more questions, we accept them in the question and answer as opposed to in the chat because it's difficult to monitor questions in the chat. I'd like to take the opportunity while I wait on the remaining questions to thank the audience again for their continued engagement and participation, to say that it was indeed a morning very well spent. We are still actually on time. And we again thank both presenters. We thank both presenters for presenting and taking the time to do it this morning, as well as the Medical Benefits Formulary Committee for having the drive to present this. And I'm hoping that everyone on the line has enjoyed the participation, as looking forward to our next 2 sessions. Again, to remind you, these will be posted on the YouTube channel. So you're gonna go to YouTube Medical Benefits Scheme for Antigua, hit like and subscribe, and follow your favorite presenters there.
I've done it.
Thank you very
much. Let me also add, I want to congratulate the Medical Benefits Scheme of Antigua. I think you have probably, well, not you have probably, you are the one Caribbean island that have arrived at your final formulary drugs in record time. And you've done so very scientifically based. I mean, you have the amount of questions I know that have come through from Dr. Cordner, questioning, well, why this and not this? What does the evidence provide this? I mean, you've done it in a very structured manner, and I think you should be congratulated for that. The country that came close was Trinidad, but they took a much longer time. I say that for Dr. Cordner, but congratulations to Antigua. You have done a fantastic job, and your formulary is really impressive.
Thank you. So I hope everyone sees where their money is being very well spent. And we have a final question for Keegan Goodwin. For a pharmacist to operate efficiently in patients with comorbidities, patient information is critical. What is your take on how do we bridge this gap? Example, health database, etc.
Yeah, of course, the S in hearts are the health systems and the data systems that kind of enhance this, right? So things like the electronic medical records, and as well as the electronic prescription. And the most annoying thing for me is having to pick up the phone, because we are still using paper-based records in the public sector, to call the pharmacist to confirm and cross-check things that I should be able to just go onto the system and pull up. Now, in the polyclinics that have started hearts, so here's another thing, they switched kind of cold turkey from paper-based to this electronic system, with very little training, with very little anything. And of course, it was a complete disaster. People just could not operate it. Pharmacists could not find the prescriptions. Patients were confused. It was, and of course, a lot of senior doctors in the system who were allergic to computers said, you know, I can't even touch this thing. I don't want to be part of this. So it's important that there is some training that occurs, but I completely understand what you're saying. What I would recommend, and I'm not sure if it is the case in Antigua, that, for instance, every week in hypertension clinic, a pharmacist rotates through the clinic. So there's a pharmacist in our clinic, and part of the academic discussion about the drugs used in hypertension, the pharmacist is there giving us the pharmacy insight into, well, I find that patients are not coping very well with this drug, for instance, or this brand of beta blocker doesn't seem to be tolerated very well. We don't get that from the individual patient, but the pharmacist gives us that feedback. So I think that's important.
Thank you. And I think our final question, I'd like Dr. Meade to rejoin us online. For the question we had skipped over earlier, Dr. Meade, a patient who has other medical conditions such as arthritis in the lower back, hips, and knees. I mean, bad progressive arthritis, where only Voltaren and prednisolone combination is what gives pain relief. What other drug would you recommend in this case? The patient is on hypertensive meds and obese. The hypertension is controlled. Clearly ironic coming from me, but anyway.
Thank you for your question. And you didn't mention heart failure patient though, because that's the group that we're usually most cautious with in terms of the NSAIDs and prednisone. There is scope to use them, but under the guidance of a specialist is what I would recommend. Because when the complications arise, what's the next management option? So the specialist, I think, would be the ideal person to manage this patient. With close monitoring, the blood pressure may rise. That's one concern we have. We would need to treat the blood pressure. The blood sugar may be out of control because of the prednisone. What are the management options? So based on the response due to these medications, decisions would then be made. But in pain control, I go more with opioid-based medication. They don't have the deleterious effect on heart failure patients, the diabetics, and the hypertensive, so it'll be opioid-based. Still require monitoring. So specialist care with adequate monitoring is what I would recommend. And it's safer for us to then monitor the patient, adjust accordingly, act aggressively, and in a timely manner. So the orthopedic team, the rheumatologists, we will all be managing the patient together.
Thank you very much, Dr. Meade. Final words from Mr. Butler now as we. Oh, I will take liberty as well and just thank again everyone for attending today's session. I apologize for going 10 minutes over the time. We promise to start on time for the next session. We will send out some more reminders prior to that. We thank all the participants, the audience, as well as the presenters, as well as our IT support. Their IT support has been with us all morning. They're amazing. We do have some kinks to iron out and have been excellently handled today. Again, just everyone stay safe and stay engaged. Look at the presentations again, download the HEARTS app, do whatever you have to do to try to treat patients appropriately. Thank you very much for a wonderful morning.
Thank you very much. Thank you.
Thank you, sir. Thanks.